CHReaD is the Coalition for Health Research and Development. It was founded in 2015 and it brings together research institutions, civil society organizations, academia and the private sector to provide an enabling policy environment for health research and development in Kenya. It also promotes access to medicines and health products.
I think CHReaD is doing a lot. We are, as members of CHReaD, we are creating an ecosystem for health innovation through the Innovators Forum. And the Innovators Forum is a platform that brings together the different stakeholders coming from academia, coming from government, and coming from the private sector.
For a long time, we have concentrated on service delivery and in health, treating and giving medicine and giving vaccinations. We have not taken time to think that by doing that, we are a market for drugs, for vaccines, for health devices, for health tools. These are things that come from outside Africa, mostly from America, from Europe, and from India, for the ones that are pocket friendly. But a time has come where, as CHReaD and as ECOSOC Kenya chapter, we are saying with the African Free Trade Agreement that was set aside by AU, we want to think beyond being a market. We want to manufacture and then sell to ourselves. So we want to awaken the giant in Africa and say, why are we importing health-related items? What is this that we are lacking? Is it the personnel? Is it the labs with CDC, with KEMRI? And as the more we relate with CHReaD, the more we realize what is lacking. For us to manufacture, to know what we are manufacturing, then we have to do research.
Digital health literally is the future of health, and CHReaD has an important role to play in the advocacy and adoption of digital platforms, digital health, and more importantly, as we go into the future, artificial intelligence that will allow us to be able to collect more information and also support the medical field when it comes to treatment and diagnosis. We are hoping that in the future, research and development will lead the progress that we have within the continent. So CHReaD has a very important role to play.
The importance of R&D is extremely important in that it is part and parcel of what happens next in terms of treatment. It is going to be one of the drivers of UHC, and it is important that we work on it and make sure that it goes, because it is the future. We know, for example, in Africa, a lot of drugs which are not being used out there in other countries, but are needed here in Africa. We don't have the latest ones because of issues of R&D. So it is important that we actualize it. And when we put in money, I think it's very important that we ring fence the money so that it does not go to other uses.
If we really care for the health of our people, then we must care for research and development. It's the only intervention that we are left with to meet the health targets that we have.
Good morning. Good morning, everyone. Good morning. It's a very beautiful morning, and above all, it has rained. So it's not as hot, and we thank God for that. So we want to get started, so if we could get settled, and then we can get started with our program. So before we get started, I would want to greet each one of you, but I may not be able to stretch my hand. So I'll rely on you to greet the person next to you on my behalf and give them a very warm handshake. Yes, like that one between Kamau and JP. Yes, Jonathan. Kirel. I want to hear that sound of that handshake. If you have not greeted your neighbor, I'll come and greet you. Have we all shaken our neighbor's hands? Yes. We must appreciate that we have come from the era where we could not shake hands. And we really appreciate the progress that we have made in that direction. So before we start, it's always good to commit the event to God. And I want to request Jonathan to pray for us.
Thank you. Good morning, everyone. Good morning. So thank you. We are going to pray, but my name is Jonathan. Thank you. Before I pray, I can share with you a verse. It is in the book of Philippians 4, verse 4. And the Bible says, rejoice in the Lord always. And I say, rejoice. Let your moderation be known unto all men. The Lord is at hand. Be careful for nothing. Other version says, be anxious of nothing. But in everything, by prayer and supplication, with thanksgiving, let your request be known to God. Let's bow down for a word of prayer. Father, in the mighty name of Jesus, this morning we come before your able presence. Thank you for the gift of life that you have given unto us, O Jehovah. Thank you for each and every individual under this sanctuary. Thank you, Father, for the journey mercies that you granted unto us. Thank you for you have brought each and every individual from different destinations up to here. We are here this morning, O Jehovah. I commit before your able hands each and every deliberations that we are going to do, Jehovah. Father, I pray that you may guide us and lead us in each and every session. I commit each and every speaker and all of us before your able hands. Give us wisdom and give us that energy and everything that we deserve before your presence, Jehovah, as we are going to start until the end. For I do pray, trust, and believe in the mighty name of Jesus. Amen. Amen. Thank you.
Thank you, Jonathan. Okay. We want to do a round of introduction. And you know, you're looking around and wondering, when shall we ever finish introducing ourselves? No, we won't do that. We are going to introduce ourselves in our groups. And I want to acknowledge all the groups that are here. And once I call your team, please stand up. And for the rest of us, let's give them a loud applause. Okay. Okay, we are going to first acknowledge the team from Amref. Team Amref, let's be upstanding. Yes, let's give them a loud applause. Thank you so much. Next, we're going to have the very energetic members of CHReaD. CHReaD, where are you? It's a razzmatazz. It's a razzmatazz. Thank you so much. Those are the CHReaD members, the group that is behind this very successful process that we are going to learn about. Okay, we have people who travel from all the way from the counties. And we know we have quite a number of them. If you're from the counties, Oh, thank you. Let's give them a Nairobi welcome. Hey, we can do better. Yes. We have to appreciate the fact that they woke up very early in the morning, I believe yesterday, traveled to be with us. We really appreciate the sacrifice and the efforts that you have made. Of course, this event cannot continue without the Ministry of Health. Who is from the Ministry of Health? Ministry of Health? Okay, let's appreciate them. Thank you so much. Oh, members of the Kenya Country Coordinating Mechanism, KCM, mko wapi? Are you in the house? Hata kama uko peke yako. Thank you so much. She's called Josephine Mwaura. She gets the advantage of being introduced because she's the only one. Thank you, Josephine. Next, members from the civil society organization, CSOs. Civil society organizations. JP. Hey, am I alone? Sylvia. CSOs. Sam. Eh? Oh, that's CHReaD. Okay, let's send again. Yes. They double us as CHReaD members and civil society. Let's clap for them. We have communities. Communities. Jerop, are you in the house? Any other person from the communities? Okay, they will come. And of course, last but not least, members of the 4 estates. I know they're holding their cameras. They're already standing. Let's appreciate them. Are there some who are seated? Members of the 4 estates? Oh, yeah, just stand up. Let's appreciate him. We really appreciate you because we always say if it's not documented, it did not do what? It did not happen. They're the ones who make our events happen. Thank you even for your coming. Did I leave anyone out? Yeah? CSOs, I got CSOs. Myself, I will tell you, I'm already standing. You'll appreciate me when I'm done. Anybody else? Okay, yes, from Global Fund, right? Yes, let's appreciate our colleague from Global Fund. We can do better than that. Thank you so much. If for nothing else, we should clap for the rain. This is something we've been praying for, and when it comes, we never get an opportunity to clap for the rain. Okay, so I want us, we're going to have a deep dive into the program. And to start us off, of course, we want to know who has organized all this and what is the reason that we are here. Of course, one of them was to socialize, meet the people you have not met for a long time. Of course, have breakfast, but what else has brought us here? And to take us through that, we're going to have Dr. Langat. Dr. Langat is a programs director at Amref. And when I asked Daktari what team he supports, who can guess? Manu. Somebody has a Mwakenya. He's a Liverpool fan. Let's clap for Daktari as he comes. And when he's not a programs director, guess what he does? He's a farmer. Yes, let's appreciate him as he walks to the podium. Yes, I've known Dr. Langat for so many years. We've worked together, fighting TB, and we have never finished. So we continue with the fight. Karibu.
Yes, thank you, Kibuchi. And really, we need to continue fighting for tuberculosis. It's amazing that it's an old disease. The cure is there. But unfortunately, even with the technology, we are still missing cases. So that's a bit of digression. And thank you, colleagues. Good morning once again. Now, it's an honor to see all of you having sacrificed your time, come early morning to join us in disseminating some of the studies that Amref, together with the government and the civil society, have undertaken. I think the mantra has always been We must be evidence-driven. We must make decisions based on evidence, and hopefully what you are presenting today is going to contribute to that. But before I do the introduction of Amref and the concept, the studies that you are disseminating, there's a small request. You will note that when you came in, you registered manually, you fill in some forms. I think COVID taught us one big lesson, that we need to digitize. And I think Amref, for a long time, we're still working from home. And I keep on telling my colleagues that I've seen a lot of efficiencies in terms of approving things, because you can work remotely. So there's a small request from Amref as part of the digitization that we are trying to launch a registration platform using a USSD code. So basically, you are given a USSD code and you fill in your details. And there's a small request that you allow us to not use your guinea pigs really, but to request you to, as part of the process, to test the system, to volunteer. So I'm seeking your consent, and I want to call Samuel Mburu, seeking your consent, that it takes you through a short process, around 5 minutes, on how to do that registration. But any future meeting you'll be attending in Amref, we don't want to be seeing that paper. We just register digitally, and your details are there. And if you are paying your transport refund, that is the basis for example, refunding you that transport. So I don't know whether I have your permission. Good. Mburu, please come in and explain. And yeah, you also need to mention about data protection. I think that is a key thing.
Thank you very much, Dr. Langat. Morning, everyone. I'll be very brief. My name is Samuel Mburu. I lead digital transformation and excellence at Amref, and we're very keen to work with our partners in terms of improving efficiency in the programs that we carry out. So today we are going to go through a simple exercise. So please have your phones ready, okay? So we're going to display for you a USSD code that you dial and a test event that we have created for today. And if you may dial *348#, kindly. *348#. Okay, so the first thing that we ask you, because of data protection regulation, is to consent for us to collect this personal data. So that's the first prompt that you'll see. Please say yes. Then the next thing, we'll ask you for your name. I hope we are all together. So *348#, consent yes. It will ask you for your name. I see Daktari is doing very well. You click send. Then the next will be asked for your ID number. Okay, and this is very important because we work with programs throughout the country, so we need to capture your unique identification in terms of your ID number. Then the next, it will ask you for the organization, so it's important for you to be recognized based on your organization. Still together? Then the next is the event ID. So the unique event ID is THQ0015. Let me say that again, THQ0015. Yes, all capital. Okay. THQ, as you can see on the screen, THQ0015. Okay. And then it will ask you to confirm your details. So it will show you your details again, just to make sure that everything is correct. And then lastly, you press continue, and that's it. So what will happen, just to elaborate on what Dr. Langat was saying, is first you'll get a unique participant ID to show that you actually participated in our events, but this will improve efficiency. So instead of our data clerks and program admins capturing all the details that you have given in the physical forms, with that manual data entry. What we are gathering today is integrated to our backend systems, and we can be able to improve efficiency in terms of our program management, reimbursement, and these kinds of activities. Thank you very much for participating in today's MoH event, and we trust that we'll work with you to improve our efficiency. Thank you very much.
Thank you very much. and really, we want to appreciate it is part of our trying to make things a bit efficient and also transparency. If at least it's real-time registration, so there's nobody who ever doubt that you are in a meeting and you're in that site. And it's part of the improvements in Amref. We pride in the agility. That is one thing that we try to make sure that whatever we do, we deliver it quicker, cheaper, and flexibility, because sometimes things are required, and you sort of have to look at what the policy says and work within that in a manner that facilitates process. So my job was basically to introduce this meeting, and of course I start by speaking a bit about Amref. I think Amref is an old organization that we were registered in 1957. So we breathed independence, and we pride ourselves in the sense that over the years, we have built a reputation as an organization that works with communities. And we build a reputation as an organization that strengthen health systems, strengthen community systems. We build a reputation as an organization that grown locally and has gone international. We have presence in quite a number of countries in Africa. Of course, our headquarters is in Nairobi. And we continue convening and engaging with different stakeholders. Whether it's government, I think we a key partner, and is the government, the county governments, and we do have programs across different fields. I think there was a mention of Global Fund. Yeah, we have programs in water, sanitation and hygiene, neglected tropical diseases. We work with the youth. We have programs on reproductive, maternal and child health. We have a young university, Amref International University. We also have the Institute of Capacity Development. I'm sure for the healthcare workers who are here, some of you might have participated in continuous professional development courses that is run by that institute. So that is Amref, and I'll be introducing my boss when he comes to make the opening remarks. It's a different business units. Here in Kenya, probably you know the face of Amref Health Africa in Kenya, which is the NGO. Then for the Coalition of Health Research and Development, CHReaD, we have the honor and the pleasure of hosting it. This is a coalition that brings together civil society organizations. And basically the focus is around research and product development. I think when COVID came in, of course, there are a lot of conversation around how long it takes, for example, to get tools you require, whether it's vaccines, to get into a setup like developing countries in Africa. And probably I think for the vaccines for COVID, of course, the world managed to cut that period, and Africa was able to access. So the job of CHReaD basically is advocacy. And basically our advocacy work is looking at, if we talk about product development, then governments and domestic partners needs to put money in research and product development. So our job is to advocate for that. We are also saying that if you want these products to be availed to the beneficiaries, then we must make our regulatory processes more efficient, more responsive. So one of the key objectives for coalition also is around regulatory efficiencies. And one of the proposals that we'll be sharing today, or the study that we did, is also looking at that regulatory efficiencies. The third objective is critically is about product introduction. We are a civil society coalition, and we do know that there are sometimes out there in the market, we have cartel products that we think can benefit the population. So as a coalition, we work together with the different stakeholders to make sure that those products are introduced quickly into the market, including it in the essential list and the guidelines. And when COVID came in, of course, we did got a little bit of money to support the introduction of COVID vaccines. And you'll be getting a study looking at the gender barriers and equity concerns when it comes to vaccine deployment. And one of the study again, which you'll be seeing here, is funded by Global Fund, and maybe just a bit of a Global Fund. I think we have had a long history with Global Fund, quite fulfilling since 2002. I'm sure Josephine Maura will, if she was to stand here, she will tell you that we have attracted in excess of over almost 11 billion US dollars for the many years. And we saw Global Fund coming in very handy, especially during the COVID pandemic. They managed to quickly get resources into Kenya through what we call the COVID-19 response mechanism. And we have attracted in excess of $100 million. And we have seen that, whether it's the oxygen ecosystem, whether it's the test kits, the rapid test kits, the PCR tests, whether it's capacity building. So one of the studies that you'll also be presenting in this meeting is we are looking at the COVID response through the lens of the healthcare worker and the patient. Sometimes when we do work, we forget the frontline healthcare workers. So we'll be sharing a study called Lived Experience. We did engage with the frontline healthcare workers just to understand how they went through the COVID pandemic. And hopefully there will be findings and lessons learned that can improve any future pandemic. So that is the program that we'll be running, and I really don't want to take a lot of time. I think it's fair enough for me it's my pleasure to introduce my country director, Dr. Meshach Ndirangu, to make his opening remarks. Yeah, I've known Meshach when I used to work in government, and yeah, now working together in Amref, and he's a renowned public health expert. He's a thought leader, so hopefully you will share some few thoughts with us, Dr. Karibu.
Thank you very much, Bernard. Very humbled that you call me a renowned public health leader. Thank you very much, Dr. I very much appreciate that. Good morning, colleagues. Mine, on behalf of Amref, is to thank each one of you for the gift of your time, for finding the space in your time, in your life, to come and have this conversation today with all of us. You know, people say time is money, but time is not money. Time is life. When you live for 70 years, or you live for 90 years, or you live for 50 years, people say he lived for 70 years. Every time when you give someone 1 hour of your time in a meeting, you have given them 1 hour of your life. So let's always remember that time is life. So we appreciate that, the gift of your time. One of the biggest gifts you can ever give someone is a gift of your time. And that's why you hear it is said that when you go for meetings late, it means you don't respect those that you're going to meet. For me, on behalf of Amref South Africa, I'm very happy to join you here today for the official launch of the 3 strategic reports on global health security, giving key recommendations that are not only critical in strengthening the response to the current pandemic, but also building resilient health systems to tackle future pandemics and epidemics. Today, we are going to do a deep dive into 3 reports done within the context of the COVID-19 pandemic. And just in case you thought that it was going to be the last one, already Ebola, I think, is in the region. Right now, our country is on high alert because of Ebola. So the reports that will be presented today, they are not about COVID-19, but they are about building resilience, country, health system, community resilience, as we forge forward as a country and also as a continent. The three reports that will be discussed today are: number one, the systemic equity and gender issues affecting product introduction access to COVID-19 tools in the East Africa region, East Africa countries. The second one is an evaluation of the regulatory processes of health products in Kenya. It's an opportunity for us to deep dive into that space and understand how to overcome regulatory barriers, create regulatory motivations and all that, so that we get more health products approved. And number three is lived experiences and effect of COVID-19 on accessibility and delivery of HIV, TB, and malaria services among healthcare workers and users in Kenya. Nothing beats the lived experience. We can talk, we can give each other stories, but until we talk about the lived experience, the experiences of those who live with a condition, who get diagnosed with a condition, get a diagnosis, and finally recover, sometimes never recover, that's the only time we can claim to truly understand our professions. On behalf of the entire Amref family, I would like to congratulate the CHReaD Coalition, and we saw all of you stand up, and also our Global Fund, TB, HIV, and Malaria team for the great achievement on these studies. And on the same note, also appreciate the agencies that have been the source of the finances for this work, Global Fund, and also the Gates Foundation, the Bill and Melinda Gates Foundation. We truly appreciate the partnerships we have with the two agencies that are also investing in research. Distinguished ladies and gentlemen, as we all know, COVID-19 dealt a big blow to the health system, and we know that it ravaged our socioeconomic fabric, not to mention the millions of lives lost across the world and thousands here in Kenya. In special recognition to the fight against the pandemic, we allowed health researchers and development actors, who are among other partners, for the rapid development of life-saving solutions that we all needed. Each one of us here at one point was wishing, how soon are we going to get a vaccine? How soon are we going to get this or that, so that we can survive, so that we can thrive? Let's take a moment to really appreciate the people, the researchers, the development actors who helped bring all this on board, develop the rapid test kits, the treatments, the vaccines against the virus. While these collective achievements remain commendable, many communities are yet to receive their full doses of vaccines. Let that sink in. You are privileged. The fact that you are here, you are deeply, heavily privileged, that very easily you are able to get a vaccine. But not everyone is like you. Let's always remember that. And what I say, you are an elite by all means. And the work of you as an elite, of me as an elite, of us elites in Africa, is to really help ensure that privileges that you enjoy, healthcare services that you enjoy, they are not exclusive to you, but they are accessible to everyone. I like to say that you are an elite. And always ask yourself, what is your contribution to this continent? Do I use my elite, me being an elite, do I use it only to benefit myself, only to earn a salary? But do you work, give extra effort to make sure we are breaking the barriers that stand in the way of access for millions across the country? That is the meaning of public health, and that is the meaning of being a public health. practitioner. The vaccines are available in country, but are not easily accessed due to a number of reasons in various countries, in Kenya, in various counties, such as limited number of facilities offering the vaccines, fixed operational timings for vaccine administration, cultural barriers, and limited vaccine awareness, among others. These are the barriers we really have to keep working to break down, working with communities. These gaps, together with other challenges and existing gaps in health research and development space, can be addressed. They are not a mission impossible, especially when we begin by tackling issues that are within our control, the low-hanging fruits, such as increasing access to vaccines, addressing social barriers such as gender barriers, supporting advocacy efforts for demand generation, and adoption of policies and practices for equitable product introduction and access to vaccines and other priority health products. These efforts should also include ensuring continuity and enhancing delivery of other conditions, maternal health, HIV, TB, malaria services during pandemics. Ladies and gentlemen, additionally, for the ease of product introduction, we need to have efficient systems for regulating and approving medical products and devices. Indeed, the Pharmacy and Poisons Board has made tremendous milestones to that effect, and we are very proud of the partnerships that has resulted in one of the reports being launched today, talking about regulatory issues. The launch of these reports gives us access to a rich pool of resources and data to guide our journey to strengthening the current COVID-19 response and also the region's resilience for future, if not current, epidemics and pandemics. As we continue along the path to resilience, we need to do more to prioritize institutional strengthening without forgetting our communities that are the reason why our professions exist. They are the center of our work and mostly affected when pandemics strike. Finally, as we get into the next sessions, a few things that we really need to reflect on in terms of some of the actions that we really need to think about. For future pandemic planning, we are calling upon the East African governments to do a number of things. One, we call upon the East African governments to strengthen community health structures for disease surveillance and awareness. And this includes working with civil society as well as community health workers. Number two, we also call for more investments into psychosocial support for healthcare providers and patients, and improving workforce management by incorporating provider coping strategies. Number three, we also call for deployment of innovative models for supply chain management, including ensuring last mile access. Number four, we also call for addressing gender and other social dimensions in pandemic responses, which are critical pillars in addressing health equity. Number five is increased budgetary support for training of staff at the Pharmacy and Poisons Boards in new areas such as vaccines, biologics, and products. And number six is utilized data repository. The data repository coming from these studies to create better market surveillance based on import data, new innovations, adverse drug effects, poor quality products, market intelligence, and regulator advisory. Yeah, so those key points are a call to action. And in addition to that, recognizing that for our country, for our continent to keep moving forward, there are two things we always need to think about. Number one, strong institutions. Whenever every country, every organization, even our own organization, every government has progressed, is because it has built strong institutions, whether health institutions or public health institutes or judiciary or whatever you call it. And so as we go through this, one other challenge to us is to ask, what are the institutions that need to be strengthened so that we can achieve all these things we are talking about? And strengthening an institution is not just about, yes, it's about governance, systems, like the way we are improving our systems here, but also it's ensuring that there are laws and regulations that support the existence and the mandate of such institutions. And I'm happy today we'll be looking at regulatory issues. And number two is leadership. Once you have a strong institution that is mandated by law in whichever field, all you need is a strong leadership. If you have a strong leader, honest, ethical, decisive, and firm, and consultative, then there is no barrier to success. So always asking, how do we get strong leadership heading strong institutions? Once again, ladies and gentlemen, thank you once again for the gift of your time. We congratulate the CHReaD Coalition, all of you who are here, for the work that you have put to deliver these important reports. I wish you well in our deliberations today. Thank you, and God bless you. Asanteni sana. Thank you. Thank you.
Thank you so much, Dr. Langat and Dr. Meshak. Thank you for reminding us that it's a privilege to get the vaccine, things that we all take for granted, and also for clearly outlining the asks that we are making to the East African community. What stands out for me is the request for more investment in the psychosocial support for healthcare workers. So thank you so much. Let's give them, we are going to appreciate them in our traditional Kenyan clap. We know how it goes, right? You know the traditional clap for Kenyans? How does it go? Hold. I'm going to lead it. We are going to go clap 1, 2, 3. You know the Nyayo clap, right? So let's go. 1, 2, 3, go. 1, 2, funga. Musifungue. Thank you. When I was acknowledging the people present, I forgot to acknowledge one very important partner, that is the private sector. And we have representatives from the private sector. If you know you're from the private sector, just stand up. Yeah, thank you so much. That is Sarah from MAC. And of course, my friend, Dr. Roberts. Let's give them a clap. Thank you so much. The private sector is always a very key development partner, especially in health. They do quite a lot in supporting the health interventions in Kenya. Okay, I want to hand over to my co-MC. I want to invite my friend, Dr. Robert Karanja. You can call him Roba. He's a member of CHReaD. Roba is a scientist. He's an entrepreneur, an investor. And when he's not doing all that, he watches Liverpool. And he also watches movies, including Gods Must Be Crazy. He knows it by heart. Karibu, Robert. So he's going to take us for the next session.
Thank you so much, Evelyn. A round of applause for her for bringing us this far. And welcome once again. And I was thinking to myself as I was listening to Dr. Ndirango's speech and the call to action, I was very moved and thinking to myself, why don't I have to invite him back here to give us some more? But we have, as he mentioned, 3 amazing reports. And for this, I want to quickly give a quick shout out to the Ministry of Health, to CHReaD, to Amref, to the Global Fund, for putting this work, for commissioning these reports, and being able to gather us here today so that we can be able to learn. There's something about COVID that I think in the early stages, I kept hearing people saying you should not waste a crisis, never waste a crisis. And I think for us in Kenya, in East Africa, actually, COVID has been an amazing learning experience. Not that we wanted it, but we found ourselves in school, isn't it? So how many are ready to hear how have we performed? If there was an exam for Kenya, if there was an exam for East Africa, if there was an exam for our health systems, how did we perform? What should we learn from this? What should we take forward? And I think those calls to action were really driven by that perspective of being introspective and saying, hey, we didn't expect this, but it's happened. What has worked? What has not worked? So I have the pleasure of inviting a few of our experts, leading experts in the health space, to come and share with us some of the information. I'll start off with Dr. Timothy Abuya. Timothy is a senior analyst at the Population Council. He holds a PhD in public health policy and has been, by and large, very involved in various aspects of our health system, bringing his wealth of expertise. And today he will be telling us a little bit about some of the work that was done, looking at the lived experiences and effects of COVID-19 on accessibility and delivery of HIV, TB, and malaria services among healthcare workers and users in Kenya. So, Dr. over to you. Looking forward to learning more.
Good morning, everyone. Thank you, Dr. Karanja. Thank you, Dr. Durango, and the rest that have come before me. I'd like to give you the perspective of the users and the providers during the COVID-19 pandemic. And perhaps just to give you the context of this work is that at the onset of the COVID-19 disease, countries set up various preventive strategies to manage the spread, but there was very limited focus on healthcare workers. And therefore, we also do know that in the initial stages of the pandemic, healthcare workers were overwhelmed with patient upsurge, visiting health facilities for COVID-19 treatment. And I think a lot of countries also reprioritized. They reprioritized resources to fight the pandemic, but there was very little focus on the providers who are in the front line. And today I'm going to present some of the findings that speaks to what happened during the pandemic. But before I do that, I would like to give you a bit of a background on what was already known during this period. At the provider level, providers were infected. Some of them even died. There was a lot of reports from developing and developed country settings that providers had a lot of psychosocial pressure. There was anxiety. Some of them could not sleep, had sleep disorders. There were incidences of depression, insomnia, and post-traumatic stress that characterized the early settings of the pandemic. All this led to increased exhaustion due to high workload, because then they had to reprioritize, re-strategize in the service delivery level. At the health system level, there were reports of interruption of services, leading to increased prevalent diseases and decreased patient attendance. I think you need to go to the next slide. Not sure whether you're seeing the right slides. Thank you. At the system level, there are also challenges of protective equipment, increased mental health problems among providers, as well as resurgence of non-communicable diseases. At the frontline level where service is provided, there were also reports from literature that suggested that there was greater risk of being infected with COVID-19 for those who either have underlying conditions, or due to treatment, travel restrictions, there are also treatment interruptions for various providers or users, especially those who had various medical appointments. Now, with this in mind, we set up this study to examine the user and provider perspective of their experiences during the pandemic. And this study was done towards the end of 2021, when the pandemic had started to stabilize. But in the initial stages, we do know that, as I mentioned earlier, the healthcare workers were quite affected heavily. There are also reports of declining notifications of TB cases. There were increased malaria cases in endemic regions and other prevalent conditions that were available. However, particularly, there were no studies that had been conducted that focused on experiences among users in the pandemic context, especially for HIV, TB, and malaria. So the objectives of the study was basically to explore the healthcare experiences in the provision of HIV, TB, and malaria, to examine the accessibility of the same, and to describe the experiences of health service use among HIV, TB, and malaria users, and to determine the effects of the pandemic on HIV, TB, malaria programming. So in the next set of slides, I will now present the results. If you can go to the next slide. We conducted this study among 900 patients. 500 of them were HIV patients. We managed to talk to 89 malaria patients and 307 TB patients. We talked to 152 providers who provide services to malaria, HIV, and TB. And we conducted 45 key informant interviews. 12 of them were case narratives with patients, and 33 were key informant interviews with policymakers and program teams. We also abstracted data from 3 program areas for HIV, malaria, and TB from the National TB Program, KHIS, from 2019 to 2021 to conduct interrupted time series analysis to illustrate the utilization trends across different diseases. This study was conducted in 6 counties with varying malaria, HIV, and TB burden. For HIV burden that was considered high were Siaya, Mombasa, and Busia. For moderate regions were Nairobi, Uasin Gishu, and the low HIV burden were in Nyeri. The TB burden, we conducted that in Nairobi and Mombasa for high burden, and moderate Siaya and Nyeri, and malaria prevalence, high malaria prevalence settings were Busia, Siaya, and Mombasa. So let me now take you through the results. And the first objective was to document the experiences of healthcare workers in the provision of HIV, TB, malaria, and HIV. Now, from the provider perspectives, we do know that although facilities were supported to manage COVID-19, there were challenges in the initial stages of insufficient supply of protective equipment for both providers and patients who showed up, for example, without masks, limiting service delivery. Also, there was a shift of resources to COVID-19, which reduced the focus on sensitization of other disease programs, including HIV, TB, and malaria. Now, more importantly, were the changing roles that providers had to adapt, such as some of them were participating in rapid response team, they were involved in testing COVID-19 and coordinating preventive measures across different levels of care. These changing roles aggravated burnout because they were either providers who were to adjust to shorter working hours, limiting service delivery, or longer hours, generating burnout. Obviously, these changing roles also aggravated staff shortages that already exist in the system, contributing to scaling down of services, including TB and HIV and malaria services. Now, the next slide just gives you a flavor of the voices from the health workers. And as you can see on your left, a very important quote from a TB coordinator who says, "My team, out of 23, 17 were attached to a quarantine center," which means that the service provision for other diseases were limited at that time. And of course, on your right, you can see an HIV coordinator saying, "Mostly we work extended hours because we manage the HIV and also COVID." So most of the time, these experiences illustrate the aggravated challenges of the pandemic. Now, from the provider perspective, we also noted that there are several factors that affected service provision. One of them is the challenges of human resource, because it required innovative ways to ensure continuity of services. And there are several ways in which the health system, the facility managers try to innovate to ensure a continuity of services. One of them is working in shifts to ensure facilities do not shut down. There was support from the national government to provide counties with providers, doctors on locum, or to work in call centers. The main challenge in the health systems was supply chain. And I think shortage of PPE, especially for providers who are managing high-risk group like HIV and TB, that needed quality PPEs, which were not readily available at that time and were pricey, made limited aspects of service provision. In terms of stock depletion, because of the challenges of flow of supplies, there were gaps. Providers talked about gaps, for example, in replacing parts of medical equipment or reagents for laboratory services, which made it very difficult to be able to provide timely supply of services. And of course, as I mentioned earlier on, human resource shortages were associated with either providers working from home. Already the system is constrained in terms of human resource. And therefore, the fact that some providers had to work from home, others were quite elderly, others were reassigned duties to work in isolation centers, creating these challenges of supply of human resource. Now let's turn to the perceived effect of the pandemic on HIV and TB and malaria. As you can see, this slide just summarizes both provider and patient perspectives on the effect of the pandemic. And the three messages that we can get from this slide. One is that general providers reported higher levels of effect of pandemic on service delivery compared to the patients. The rates were between 95%. However, they also reported lower levels of the effect of pandemic on malaria services compared to HIV and TB. And thirdly, among patients, we see a significant difference in those who reported that COVID-19 affected HIV and TB, with the least being TB services. And the message could be that the strengthening of HIV TB programs for a long time could be beneficial during such periods of pandemic. So if you look at the nature of pandemic from the providers and patients' perspective, the common effects that were reported by providers include, temporary closure of facilities or either health workers contracting COVID-19. We asked them, do they know any provider, for example, who had contracted? And 80% of the providers said, yeah, I know someone who had contracted, a provider who had contracted the condition. The facility hours also changed because of the outbreak, and they did some changes on how HIV, TB, and malaria services were managed. Patients also reported changes in clinic appointments, lack of laboratory services, or long drug refills, or missing appointments, or due to either restrictions of travel or failure of provision of services from the health system. As I mentioned earlier, the system itself, the providers and managers, did deploy certain strategies to support continuity of services. And most of them are highlighted in this, and I'll point three main ones. One is the use of telehealth services, which meant that they were able to strengthen now to remind patients on drug pickups and return dates. There are various forms of differentiated care, either adjusting dispensing period to minimize clients coming to the facility at one point to avoid crowding, or rescheduling clinic visits so that they were able to talk about early users or experienced users of the services so that they stagger their service provision accordingly. And of course, as we all knew, they also enforced preventive measures through security measures at the facility level to enable continuity of services. Now let's move on to the second objective of the study, which was accessibility. And I'll not bore you with very complex graphs, but I'll tell you what it's all about. So we looked at utilization trends of HIV, TB, and malaria services from 2019 to the end of 2021. And we also looked at outpatient data across from the Kenya Health Information System to try and look at the utilization trend for various services. Now, we did an interrupted time series analysis, which basically looks at two time posts of the interruption. The first was in March 2020, when the COVID-19 was declared a challenge in Kenya. And the second interruption, which is in the second graph, in the second line, you can see the vertical line there, is a time when the COVID-19 vaccines were made available generally to all populations. And so these two graphs illustrate two things. The first on your left probably indicates, I think it's on your left, yes, utilization trends of patients of under 5 patients for under 5 years. And as you can see in that graph, the first interruption, as I said, in every graph that I'm going to present, illustrates when the pandemic was declared in Kenya. And we can see that the under 5 utilization was declining just before the pandemic and continued during the pandemic, but did not change much after the introduction of COVID-19, so the second interruption. There was a slight improvement on utilization of under 5 across the country. If you look at the other graph for patients above 5 years, you see, again, a declining trend just before the pandemic, which went deeper after the pandemic, but picked up after the COVID-19 vaccines were introduced. If you look at the revisits, now that was the first visits. If you look at the trends in the revisits for outpatient service use, again, we structure this with the under 5 and over 5 years. Again, the under 5 revisit was increasing just before the pandemic, but declined significantly after the pandemic and increased after the introduction of the COVID-19 vaccines. And the same was seen for the patients' total revisits for over 5 years, with the trends increasing after the introduction of the COVID-19 vaccine, but dipped with a big slope just after the pandemic. If you look at TB cases notification across the country, the number of TB notification was declining before the pandemic, which dropped further in your first graph during the pandemic and increased after the introduction of the COVID-19. And for MDR, multi-drug resistant TB notification, actually prior to the pandemic, this was quite increasing, and then it went down after the pandemic and didn't recover quite easily after the COVID-19 vaccines were introduced. If you look at trends in testing for malaria services, an interesting trend comes here. At the facility level, there was already a decline of malaria cases tested during the pandemic. However, the cases began to increase after the introduction of COVID-19 vaccines. Now, at the community level was a very drastic shift with a big drop before the pandemic, but then this testing at community level increased significantly both after the pandemic and the introduction of the COVID-19 vaccines, meaning there was a potential replacement of service use from the facility to the community level, which was highly a good thing. In terms of treatment, a similar pattern. We see a drop just before the pandemic for treatment at facility level, because obviously for malaria disease, you have to test and treat. So a similar pattern is seen at the community level, a higher uptake of treatment as opposed to the facility level from the previous graph. For HIV cases, HIV testing and counseling was generally declining before the pandemic and continued to decline with a slight drop during the pandemic and after the introduction of COVID-19 vaccines. And you look at the trends of HIV cases put on treatment, it was also just declining before the pandemic, but appeared to increase after the introduction of COVID-19, but we don't have a big slope of that increase. So finally, I would like to give some reflections on experience of service use among HIV users during the pandemic. And 5 messages can be generated from the user experiences. One, we do know that patients recorded either missing appointment or having challenges accessing services. And 42% of them mentioned that they incurred extra costs in seeking medication. 40 Okay, can get another microphone? But I'll continue. Thank you very much. There are 3 fears expressed during the pandemic. One is the fear of discrimination, especially among TB patients who are often mistaken for COVID-19. There was a second fear of being infected for those who already had immunocompromised conditions like HIV and TB, and fear of being tested because of the related consequences of being put in isolation and quarantine. Of course, there are challenges of financial and social constraints as a result of supply chain challenges, leading to unavailability of drugs and testing services. Therefore, in the context of a very low economic activities, patients reported the challenges of being able to incur extra costs. And due to the changes in the way services were provided or appointment, they contributed largely to missing either medication or increasing costs. And this summary of voices from the patient gives you a flavor of what happened. I'll just read one quote. Challenges: you might be traveling and the cough comes about. You find that you're isolated. Each time you cough, everyone wears his mask. You're always worried in the car. What will they think about me? At times, even at the market, they'll think I have brought corona. So you can see from a case narrative from a TB patient saying, you know, these are real issues that affected the service, or rather the experiences during that period. Let me now give you a flavor of what happens to malaria programming, or the programming of the disease, as my last objective, the effects of the pandemic on programming. And providers generally rated the effects of pandemic on the health system, top of them being availability of essential services, second was drug and supplies, and third, quality of services was affected. So this is the rating of providers saying, on a scale of 1 to 3, how do you rate the effects of pandemic on these aspects? And they rated availability top of essential services, and least was cost of services. Obviously, they also talked about the normal interruptions of financial operations of the health system. We also noted provider absenteeism during the pandemic. 6 months prior to the survey, 60% of the providers reported being absent. And during the first 6 months of the pandemic, 48% reported being absent for work. And during the first 6 months of the pandemic, I think it should be the next slide, the reasons for absenteeism during the first 6 months were either they were personal leave, on personal leave, or there was substantial number, almost a quarter of the providers saying they did not report to work for fear of violence that was targeted to health workers because they were thought to be the ones spreading the disease. And of course, caring for the family, and about 12% of them reported being sick related to COVID-19. So what recommendation then do we draw from this report? One is, at the community level, we need to strengthen community health structures to complement other levels of care. We saw how services, testing and treatment services for malaria was replaced at the community level. And therefore, community health workers will probably play a big role in ensuring that they can manage the conditions that are not severe, to decongest facilities. And you can strengthen their ability in terms of community health system to be able to address the information, the social behavior strategies to enhance and reduce stigma and discrimination during such pandemics. At the facility level, important to note that providers were extremely affected, and you saw 22% of them saying that they could not report for work for fear of being targeted. And therefore, this could have generated trauma and stresses of work, and they were overwhelmed because of the large numbers of patients that came in for treatment of COVID-19 during the initial stages. So enhancing psychosocial support for them and capacitating both community-based counselors who can provide such services to providers. And of course, improve service provision, workforce management. One important thing we saw is the changing roles of providers, which actually they probably had not been were not able to cope with the very evolving pandemic issues. So empowering them to be able to change with the dynamics of the pandemic would be great. At the program level, we've talked about innovation of supply chain management. If we can create a period of buffers, because, for example, we can create regional hubs for effective management of procurement. Because if you have supplies for 6 months, 8 months in a regional center, we don't have to worry about supplies that come from abroad, those can help us sustain for a period of time. And of course, if we create a basket of funding for pandemic preparedness, as Dr. Ndirango mentioned, it will improve efficiency of accessing funding during emergencies to minimize disruption. So, ladies and gentlemen, I'd like to say that overall, the pandemic resulted to moderate disruptions of HIV, TB, and malaria services. From the user perspective, there were changes in service delivery arrangements, which generated social and economic costs, and limiting opportunity for accessing care promptly, and a lot of supply challenges around commodities, safety gears, and stigma really challenged our users. Despite all these challenges, we've seen that health systems and facilities managers designed and implemented mitigating measures to support continuity of services. And therefore, we have a great opportunity for all of us to learn from this, and we could, as I mentioned, strive to create innovative model for supply chain management, improve efficiency of service provision through workforce management, and enhance psychosocial support for providers. So thank you very much. And I would like to thank all colleagues who were engaged in collecting data, county governments of Busia, Siaya, Uasin Gishu, Nyeri, and Nairobi, and Mombasa, and colleagues who are coordinators, Kuya Millicent, Jean Serek, Timothy Kamau, Jane Gitai, and many more that I probably would not mention here. But thank you very much, and I'm happy to have lots of discussions later during the session. So thank you very much, and over to you, Dr. Karanja.
Thank you so much, Timothy. Another round of applause. Jameni, I think, for me, I think I've been learning a lot, and I think we've just seen what was the experience like for patients, and sometimes we forget the healthcare providers. And so, new word, psychosocial support, isn't it? That they are also human beings. They also go through a lot of stress, and in the way of having to be brave and put up a brave front. The interesting thing for me that stood out was that the patients did not even believe that things were as bad, which tells you there's a lot of shielding that was being done by our healthcare providers for us, the public, not to understand just how grave some of these things could have been, or actually were at the time. So having looked at that angle, I want us to shift gears a little bit. You know, when we are sick, when things are not working, there's this common saying in Kenya that we say, serikali ni nisaidie, isn't it? We don't know who is this serikali. We don't even think about psychosocial support for them. But one of the people that working behind the scenes in terms of making sure that the health system actually has the drugs, the vaccines, the diagnostics, the medical equipment for being able to provide the care is the Pharmacy and Poisons Board. And so we'll also have a quick review of what it did actually take to make sure that these health technologies that we needed in our health system were available to us at this crucial time. And for that, I'm going to invite none other than Dr. Chris Masila. Dr. Chris is a pharmacist. I don't think he's a practicing pharmacist, but I know he knows quite a bit about drugs. Do you practice? No. That's because most of the time that I've known him, actually, he's been one of our leading practitioners. He's an international consultant in healthcare issues, and also the founder of Pract Health Consulting Group. And I think he's done quite a bit of work, not just in Kenya, but in the region, in various forums that we've been meeting. And so he'll be telling us a little bit about the status of our National Regulatory Authority, the Pharmacy and Poisons Board, and how this and how prepared we were, or the work that they were doing behind the scenes to make sure that the healthcare provision could continue. So karibu sana daktari, the floor is yours.
Good morning, everyone. And all protocols observed. Thank you, Dr. Langat, Dr. Ndirango, for this opportunity. I think my predecessor, Dr. Buya, moved quite well in terms of where we're moving to, in terms of regulation. And there was a famous saying when COVID was just came into the country from the CS Health: if you continue to behave normally, this disease will treat us abnormally. So we've learned quite a lot for the last 2 years, and we are still learning. And we hope through this, sharing some of this exciting work that has been done over the last few months, you'll gain a lot of experience. So this particular work was done between April to June this year, and really focused a lot on the evaluation of the health products regulatory review process. And we focused mainly on the Pharmacy and Poisons Board. Definitely there are other regulatory bodies which are there, and we have noted this for further insights, for further future research. Some of the objectives we really wanted to focus on was, one, looking at the current regulatory review process. And here we were looking at a number of health products, from vaccines, the medicines, devices, and other category of products. Another key objective was really looking at the milestones. What are some of the key milestones that the regulatory body has achieved, timelines, and also assessing impact of good review practices when it comes to registration of some of these products, critical products. Efficiency, and also some of the challenges and opportunities. Many regulatory agencies across Africa are going through a process of enhancing their regulatory approaches. And PPB is one of them, and they have adopted the WHO more or less global benchmarking approaches, so that they're able to move from various maturity levels. So these are some of the key objectives. Of course, for this presentation, we'll not cover everything. We'll cover some of the key highlights from this. Next slide. So in terms of approach, we applied mainly a qualitative kind of approach. Of course, there was some quantitative approach. As you know, some of the information from the regulator is confidential. So more qualitative, but we tried as much as possible to get a lot of quantitative data. And one key thing is we spoke to a number of stakeholders, not only policymakers. We spoke to the private sector. We spoke to regulatory experts, international partners, and also key people who are influencing regulation. Definitely we used some of the tools that are used globally from WHO, from the Center of Regulatory Science, to really come up with a very simple tool which will be able to gather some insights. So all this process really took us around 3 months to really gather some insights, go to the field, get some key rapid desk reviews so that we're able to inform some of the findings from this report. So I'll share some of the key highlights from the report. We have a huge report which is going to be launched and has huge insights which I might not really go into at the moment. One thing we wanted to share is what has worked well and what has not worked well. One, I'll start with what has worked well. I think one key message from our evaluation and even from our team was the digital transformation for the Pharmacy and Poisons Board. 5 years ago, they launched something called the PPB Regulatory Information Management System, an initiative from the CEO and also some members of PPB. And this has transformed delivery of service and making it more efficient. So a lot of the services that are offered by the board are quite moving away from manual. 10 years ago, most of the processes were very manual, paper-based. And if you go even for beyond registration, even if you go to your nearest pharmacy, there's something called the health safety code. And using an SMS, you're able to confirm that this is a legal or a legit pharmacy out there. So some of this actually prepared us even before COVID, the digital transformation. One second thing is there's been a lot of support for a number of partners, especially from Global Fund, the USAID, WHO, and other partners like the Gates Foundation, CHReaD, Amref. I think this is really great for the regulatory agencies here in Kenya, because this is where we need our products to be safe, efficacious, and of good quality. I think I've mentioned about the guidelines. Most of them are online. If you log in right now to the PPB website, you'll see a lot of this information readily available. One thing that Kenya stands out is really monitoring of adverse drug events and also just post-market surveillance. Kenya is a center of excellence in Africa for pharmacovigilance and has been, I think, for the last many years. So I think recently they launched an electronic system where you're able to, even as a member of public, if you see any adverse reactions, you're able to report using SMS. And I'm sure the representative from the board will talk about that. Another thing is we have been talking about COVID and the porous borders. I think what the regulators in the region in East Africa have done is try and have a regional harmonization process. The East Africa community set up a mechanism, the medicines harmonization process, where you're able to really monitor across the region and harmonize several standards. Clinical trials, I think they have one of the best when you compare to Ghana and South Africa. I think we had the equal measure. Some of the comments that were coming from stakeholders were the issue of technology has been really good, and also the process of having harmonized standards when it comes to medical devices. If you move to the next slide, what has not worked well, and this is where some improvement would be required. From our assessment and also other assessments which have been done by various organizations, the aspect of human resource is also a gap which needs to be addressed by either the government, the funders, and a number of experts. The M&E and research capabilities are still nascent and still need to be supported. I think my previous presenter mentioned a lot about research about COVID. I think this has to translate also in the regulatory sciences. When it comes to submissions of products, we spoke to some distributors, importers, manufacturers. There's no follow-up in terms of first in, first out, in terms of regulatory approvals. The regional harmonization process I've talked about, where you can register a product in Tanzania, then you don't need to register in every country. Still, there's low awareness about that. As much as technology is great, sometimes having so many one system doing a lot becomes a challenge. So fragmentation has been a problem. And also on medical devices, still there's more work to be done. I think these were some of the comments from stakeholders who we talked to. Some were mentioning the turnaround time was quite lengthy when it comes to from 2 years to 3 years. There's also need for, I think Dr. Ndirangu mentioned about experts needed in terms of vaccines, biologics. Some of the interviews we held, next slide, from both private and health researchers mentioned there's need for efficient and more screening when it comes to tracking the approval processes, a more integrated IT infrastructure, and a more transparent board. I think these are sentiments from various stakeholders out there who actually said these are some of the things that would like to be improved within the agency. When it comes to efficiency, next slide, we really looked at the board has a customer service charter where some applications by the end of 1 year or 2 years, every step in terms of timelines. And this is great for efficiency to manage, especially from an applicant perspective. When we analyze that data, we'll see from the report, some of the evaluations actually took much longer, more than 2 years. And sometimes this prevents product entry into the country. And the timelines that were provided were inclusive of PPB's time. So I think there's need for separations of the timeline in terms of when the approval process is going on. One thing that the board and also a number of regulatory agencies have done is adopting the reliance and abridged review models, which are really useful, where they use some of the WHO pre-qualified regulatory agencies or stringent regulatory agencies to really fast track the various processes. So this is slowly being adopted and being used as best practice. In terms of good review practices, this was another element. There's a whole component on this. This is standard for assessing regulatory agencies. The medicines and vaccines actually go through the similar processes. Medical devices, still there's involvement of expert review committees. There's also, PPB is also ISO certified, and it's a good thing in order to have a quality management system being implemented. There's also capacity building ongoing, and also twinning programs where staff from PPB could work with, for instance, Rwanda, Tanzania, WHO, in terms of bringing specific technical assistance. Next slide. One key thing that we looked at, one of the objectives, was the global benchmarking tool. This tool is basically used to perform evidence-based assessments and compare national regulatory authorities. And PPB has been part of this for a number of years. And as you see there, national regulatory authorities through independent assessments could move from maturity level 1 to 4. And when you look at 1, it's the most basic level. And some elements of regulatory systems exist. As you move towards 4, you will see quite sophisticated when it comes to regulatory processes. I don't know if it's visible, but we have a number of countries, not many, who are at maturity level 3 and 4. In Africa, we have Egypt, Nigeria, Tanzania, and also those are some of the countries and Ghana, which have come up as leading regulators in the region. For instance, Egypt just recently received approval for medicines and also vaccines producing maturity level 3. So I think this is where Kenya has been really looking forward to graduate based on these WHO assessments. Previously, we have been at maturity level 1 for a number of years, but I think recently, and I'm sure the PPB will mention, we are moving towards 2 and hopefully in the near future to 3, so that we're able to really, some of our complex products which we produce currently could be able to export to other markets. In terms of opportunities and some of the bottlenecks for why we need to attain maturity level 3, this is something that a number of regulatory agencies, especially with COVID-19, has pushed a number of African regulators. We need to move towards this. We only have a few, and most of the ones who have maturity level 4 are mostly in developed countries, who are mainly the stringent regulatory authorities, which PPB works with. The plan, I think, from PPB is to really move towards this. We want our products, I think we have talked about test kits, the vaccines and all that, need to attract a wider market base. We need to also sell our products to players like Gavi, UNICEF, Global Fund. I think recently I saw a farm, local farm, Universal, one of their products has been WHO pre-qualified, the malaria, anti-malarial product, SP, and a few others. The other thing is also the partnerships with African agencies. So Africa CDC, there's these partnerships on African vaccine manufacturing. There's a lot of push towards the board and also other regulators to really move to this level. So the journey towards maturity level 3 still is pending. We still have to revise our legislative instruments so that they are aligned to new mandates. Currently, PPB, before they started only regulating medicines. Right now, they regulate all the health products in this country. So this comes with additional requirement to really change our legislation. The legal reforms, they have started this. There are a number of rules that have been set up. The digitization, of course, has really helped in terms of moving towards this. Still, the staff numbers need to be improved. And another point in terms of vaccines, most countries in Africa, because of COVID, are trying to see how best to start manufacturing vaccines. In Kenya, with the Kenya Biovax Institute and also Moderna coming in, PPB definitely is challenged towards ensuring that we move to this level to be able to really undertake good manufacturing practices. However, I think still the country can manufacture vaccines, but definitely some of the vaccines cannot be eligible when it comes to procurements by Gavi, UNICEF, because they control almost 90% of the African vaccine market. So some of the key messages I think have been mentioned. I don't repeat some. I think I'll just emphasize one or two. One is PPB, despite some of the challenges, has really moved quite a number of milestones. The last 10 years, there's been a lot of transformation when it comes to certain segments of the regulation. Definitely, there's a push towards having more local manufactured products, and they have really been supportive of that. The human vaccine manufacturing plants, I'm glad the private sector is here, have really tried to work with the regulators to ensure this is happening. Recently, we had the Africa Medicines Agency, and definitely it's going to be hosted in Rwanda. Unfortunately, Kenya lost, but we still have an opportunity to work with them to really, the Rwanda and also the other African agencies. I think at the moment, the cabinet, I think the last government approved the treaty or ratified, but it's still yet to be endorsed by the parliament. So I think this is something Kenya is still pending when it comes to ratification of the Africa Medicines Agency. I think finally is just the strategic advice. I remember the PPB teams used to be in the COVID task forces, and they used to offer a lot of scientific advice, regulatory advice, even when the new vaccines came in. It was really important for the task force. I think this should be strengthened more. In terms of recommendations, some of the recommendations, one is on efficiency and effectiveness. We've talked about this. There's need to invest in terms of monitoring this, invest in more faster regulatory pathways, need to track this. PPB is implementing a time-stamped system, which should be able to track from both the applicant and also from them as a regulator, how much time it takes for you to get approved at various stages. There's need to sensitize a number of stakeholders on the various systems which are there. There are a number of systems, a number of applicants and private sector are getting confused. The integration is really key for the infrastructure. Investment in M&E and research, I think Dr. Karanja, CHReaD and partners here is where I feel there's need for supporting PPB will be great, because this is as they are pushing the aspect of ensuring we have good products, we need to do some bit of monitoring and also some research to help that. In terms of strategy and sustainability, this is important for, I think, for this forum. There's need for increased funding. Most of the funding PPB gets is from the registration and licensing. Rarely do they get from the Ministry of Health or from Treasury. I think, and also some of the partners who really support them. So there's really need for increased funding and also trying to look at from the PPB angle, kind of as an investment for the country. I think this is something that the CHReaD Regulatory Committee mentioned. This is really key to see this as an investment and for the economy to grow. We need to have a functional and proper effective body. The other thing is also specialized staff. As you heard, we have a lot of complex products which are out there. We didn't know we'll manufacture vaccines one day. Right now, we are in the process. So we hope as these capabilities of manufacturing come in, we need the board also to upskill their resource so that whenever you produce the vaccine, there's lot release. And this is really important process. So you need to have been trained in some of these processes. The other point is the PRIMS system, the information management system, needs to be more adaptive, and they are now more integrating with other systems. There's need to think about accelerated review and also performance standards. As I close, some of these key reflections from our work we thought we would pose to various stakeholders. One is there's a lot of countries or regional economic blocks are moving towards this. At the globe, we have, for instance, the Pharmaceutical Inspection Corporation. We have recently the Stringent Regulatory Authority changed to WA. And we all have these regional arrangements, the ESC, the African Medicines Agency. We need to ask ourselves as PPB or even the Ministry of Health, where do we sit or what position do we take in some of these regional and global contexts? The next thing is human resources. One thing I think we in the country, we lack a training in regulatory sciences. Most of the people who are trained here have to go in Europe or other countries to get trained. And once they're trained, they get poached by WHO, Global Fund, and we remain back to the same position. So I think staff retention and ensuring some of these sciences are covered is really key. Metrics, regulatory metrics is really key. We have seen this is one of the major gaps in regulatory bodies, and there is a lot of time spent on applicants' approval. In Africa, most of the approvals take 2 to 3 years for you to approve a product. When you go to other jurisdictions in Europe and all that, this takes almost a year or less. Of course, there's the emergency use listing, which has really improved for some of the products. But I think we need to improve this so that we have good products, innovative products in the market. There's the aspect of sustainability, the fees, regulatory fees. We need to think twice about how it's costed, and could we think about having a more accelerated review of applications? We have seen this in Tanzania, Rwanda, and other stringent regulatory authorities have started adopting this. It's really key for us to think about when we move to complex manufacturing. The other point is the product focus. A number of the maturity level 3 or 4 bodies, they usually focus only on the products, but the aspects of practice is done by another body. In Kenya, this is combined together, where you have the same body regulating products, regulating the profession, and doing a number of things. And this really stretches the body. So I think for the government and also the ministries to think about, is there a need for separation of these various bodies so that we have someone regulating only the products, then we have someone regulating on the professional. We have seen it work a bit well in some of the SRAs, stringent regulatory authorities, but I think this is something that the country needs to consider in order to have a more efficient process. Technology, tracing, I think some of our products which we have in the market, once they are registered and you want to follow them up to the facility, you cannot trace them. So we need to think about how some of these interagency collaborations would work, where, for instance, PPB would work together with, for instance, KEMSA and other supply chain bodies, so that as soon as the product is registered, you use some tracing technology like GS1, blockchain, so that you're able to trace the product up to where it's used in order to prevent use of counterfeits and other aspects. And finally, in terms of devolution, we have seen PPB set up regional offices. However, as a team, we think counties could play a bigger role in terms of having county HPT regulatory functions and capabilities. And in the spirit of devolution, I think there's need for trying to empower some counties to really be able to support the board in these efforts of regulation, because it's a lot of work at the end of the day. So these are some of the key reflections, and we thank all the team players. I think we worked with a number of people. Dr. Langat was very instrumental in ensuring this report is of the highest quality, and the team there at CHReaD. We thank the Pharmacy and Poisons Board, Dr. Sioi, who's not here, the CEO, Professor Mbwiri, the Deputy Director, and a few of the technical teams who are really valuable to this research. Of course, Amref, CHReaD, and the Gates Foundation who financed this. And of course, a number of players like KHF, Dr. Nyalita, I see she's here, and other private sector bodies who are really key. One thing I just wanted to mention is some of the resources we have from other jurisdictions are really helpful. There's this Center for Innovation Regulatory Science. It's one of the top think tanks when it comes to regulation. And of course, Africa Union Development Agency, AUDA, has a lot of resources to share. So thank you very much. That was the team that did the work, saying thank you. And of course, all the partners of CHReaD who provided valuable insights. Thank you very much.
So thank you so much, Chris. It's a great job you've done, and thank you for taking us through the behind the scenes. You know, as you heard, I like watching movies, so sometimes watching the making of the movie, you also tend to learn a lot. This is kind of what it takes to make sure that our supply chain, the products are actually in place, we're getting the right products, they are working, they are efficacious, they are safe. So it's not a small issue. And I think the biggest take home for me, I think I'm super biased as private sector, is that we need investment. This is actually a check on how much can the private sector invest if the regulatory aspect is also not getting investment. So we really want to call on the government to, and Treasury to actually look at it keenly as an enabler and as a driver of the Kenyan economy. Next, we want to shift gears. We want to, and before even I do that, let me first a quick shout out to our online audience. Are you there with us? Can you raise your hand on Zoom? You know, some of these things, COVID has taught us a lot, by the way. You know, we've learned that we can do hybrid events. And I think we have participants also joining us outside of this room. So let's, cameraman, can you, let's wave at them. Don't show my face. Just show us, show the audience so that they feel welcome. Asanteni. So thank you so much. I want us to shift gears a bit. I want to introduce our next speaker, who is also a great expert. He's called Dr. Daniel Mwai. He is a senior lecturer at the University. Can you say the University of Nairobi? So wale wengine that did not go to the university. We were told there is schools and then there is polling stations. So anyway, so I want to invite to join us Dr. Daniel Mwai. He's a senior lecturer at the University of Nairobi. He is actually leading health economist and health financing expert. And he will talk to us about the equality or the equity aspects of the COVID. What did it mean, not just to us overall as a public, but there are aspects, the components of our society that we tend to leave behind. Earlier on, we talked about the healthcare providers, but I think now he'll educate us a little bit more on what happened to the health system. How did we perform in terms of making sure that health, whether it is the testing for COVID, the vaccination, the treatment, were we equitable? So, Daktari, karibu sana. And I think you are working not just in Kenya, isn't it? So, which countries? Southern Sudan, Rwanda, Burundi, and Uganda.
Southern Sudan.
And Southern Sudan. Thank you. So come and give us a perspective of East Africa and how we all performed. Thank you.
Thank you very much, Dr. Kalanja. And good morning, everyone. So I think majority of the people who I interact with, I'm talking about money every time. So at least today, I'm not talking about resources, but we are presenting an analysis that we have done within the region on equity and systemic barriers to COVID-19 tools, introduction and access in our East African region. So as I present, I want to take cognizance of gender expert Tabitha, who is not with us this morning. She said that I give you her greetings. All right. So I present this analysis, first highlighting the few issues that, of course, we know within the healthcare system, that the healthcare system has one side, which is demand, and the other side, which is supply. Us as providers of service, we are ideally giving people services to take anyway, but the person coming to seek care is from the demand side. They must perceive, that the care is important, the service is critical, and then their perception brings them to the facility where they receive the service. And we are highlighting that equity and gender considerations are critical in service provision, not only for COVID, which is our learning experience here, but also in other aspects of healthcare provision relating to, diagnostics, provision of vaccines, among others. And we are highlighting that, with the discrimination practice that are ideally embedded within our system, not only the social system, but also our healthcare system, so to speak, then this could undermine the ability of the demand side to respond to the supply initiatives that we are providing to make them to receive the service. And then with this, then we are highlighting that a good system that was providing for COVID vaccinations as well as uptake of the tools that are, being introduced, then must take into consideration these aspects. To achieve this, then, we are saying that an equity component is important, where we talk about either vertical or horizontal equity across genders is critical for, fairness in the introduction. So we dig into understanding the gender and equity issues that, really related to the introduction of the COVID tools, mainly vaccines, diagnostics, and such. And also we look at the data disaggregation in terms of gender, within the same. We also look at the drivers and barriers that we could highlight for equitable and gender sensitive COVID-19 vaccination access and provision, as well as also look at any other barrier that exists. So in this consideration, then, we looked at inclusion of women, PWD, and other vulnerable populations, who also including the marginalized populations. We collected the data across our East African countries, as highlighted, Kenya, Uganda, Rwanda, Burundi, and Southern Sudan, where data was available, and to the magnitude it was available, so to speak. And then we looked at different differentiated services models that were provided to introduce and give vaccines, how demand was created and who was actually the receiver of the same, different roles that gender plays, as well as, of course, the knowledge, beliefs, and practices that are a driver to, uptake. Then in terms of methodology, we would highlight that we relied largely on country data, and much appreciation to the countries who provided their information for us to do the analysis. And we did the review. We had extensive stakeholder consultation for each of these countries, targeting the frontline providers of service to make sure that we get the real insights coming from the receivers of service. And this were also supplemented by key informants, and this data has been analyzed, and more details have been provided within the report, which I don't want to take long to actually explain. So I want to really quickly highlight some of the main findings. The others, again, are in the report, and I'll be happy, if you could take some time to review. We are told that if you want to hide something from the Africans, you put it in the books. So I am assuming this is a saved team that ideally will not fall into that trap. And ideally, they will take some time to quickly review and take insights for the 3 studies that have been presented this morning. So we want to first highlight the composition of the COVID-19 response committees. And we want to first highlight that 81% of them were made of men, right? And within that 81%, we are finding that 0 are headed by the national, by women when we look at the national committee. And here we are talking about the countries that we have reported there. You can already see, and this is a good way to start, is it? All right. Now, if we are talking about equity, then it is important for us to really have better representation in these responses. The second is, of course, a report on infection rates. Next. And here we are highlighting that we find that men were largely infected, by COVID-19. And also the mortality rates for the same gender were high. That means the burden was, leaning towards affecting more men than women. The next thing we highlight is the vaccination penetration. And this data is, there are two reports in the report. There are two tables in the report. One highlighting the, the introduction period and then later. So this is the aggregate between 2021 and 2022. And we find that largely, except for Kenya is almost the same, 50.9, Sudan 52, Burundi 60, and Uganda 56 for men. When you subtract from 100, you get the proportion for women. But more importantly is that you'll find when you interrogate the report that within 2021, a country like Southern Sudan, we had 70% men and 30% women. So these are women did a cash up because of course, addressing some other variables and factors that we could actually see as we interrogate the report. Then we realized that there was a huge lag in, of course, the vaccine for the age 13 to 18, which can be explained. But a key point to actually make note of is actually the issues relating to economic empowerment of different groups. And you find that higher income and highly urbanized sub-regions had more than twice the uptake of COVID vaccine compared to low-income sub-regions. So that tells you that if you are a poor, you are kind of discriminated in all ways, including access of this kind of vaccination. And I think this is something that really should not happen if we are looking at equity dimensions. And then the other one is relating to, literacy level. And you find that with around 50% literacy level, the vaccination was 34.2. And with the literacy level of around 13.1, then the vaccination was around 23% approximately. So again, you see the role of education to our people as they partake or adopt various treatment options that are introduced. So I quickly highlight the barriers identified. And a key point here is belief, myth, and misinformation. Remember, when you introduce a product, for instance, a vaccine, for it to be received by households, the way the household understand the risk premium, as well as understanding the importance of what you are bringing to them, not to you. To you, it could be very important. And I think we have been blamed in the health sector for having a very high premium for being well compared to the other premiums that people are praising. So we find that we need to look at the issues of fear of risk of exposure, because people felt that when you go to a vaccine center, if you're not sick, you'll get sick. So they don't go. The other one is vaccines would cause death and shorten lifespan. These are issues that have come. The other issues were related to fertility of both men and women. And of course, the religious beliefs. This was, of course, against God, and it's not supposed to actually be happening. We should play this kind of mates. The other one relates to a number of facilities providing the service, the geographical distribution, and accessibility for the same. And more importantly, this was a key problem in Southern Sudan and Burundi. Operation days and timings for the same. Vaccination between 8 and 2 p.m. when the active population is actually not really thinking about health, is thinking about their stomachs. So they are looking for resources to eat or consume that day. So by that time, it's a time you are vaccinating, so they don't really come for the same. Inadequate information to the communities, and this calls to the civic duty as well as the role of the CSOs in actually pushing the agenda of knowledge among the people who are supposed to take the services. Of course, providers who are few. Some countries like Southern Sudan and Burundi, Lili, you would have to travel for long distances to go and access the vaccine. And one of the complaints was that women were not even traveling, and they don't travel a lot, and therefore they were not able to access these services accordingly. In terms of gender norms, we find that the health workers, those proportions reported there, they reported that gender played a key role in the uptake of COVID-19 vaccination and other tools, including diagnostics of the same among the women. And the key cited factors: one is limited decision-making power, that you need clearance for you to go and get a vaccine. And if the person who is you are getting clearance from actually is the one who has no knowledge about the issue, then you and the person, of course, you don't access the vaccine. The limited time due to household caregiving laws. Of course, people are busy at the household level taking care of those who have actually closed schools, so they are at home. So you should stay at home, and ideally, they were not going to access these tools. And of course, dependence on men who control resources. For you to travel, and also for Southern Sudan and Burundi, you need resources which you don't have. So if you have no resources to travel, then that becomes a barrier for you to access these services. The countries tried to respond by putting some few measures to try and address this problem. Among them, countries intensified the provision of better technology in registering and extending the facilities that were providing the service. The other thing was that data uptake of COVID vaccine was well disaggregated for some countries, as you see in the report. Others did not disaggregate data, so actually you don't know whether it's a male or a female. They just recorded a vaccine was provided. You have no idea to who they provided. Identification documents were critical, but not a mandatory requirement in many countries. And you could see that some countries did not require you to identify yourself as a mandatory thing. And this was reported for Southern Sudan and actually Uganda. Timing activities were some made to be friendly, to the population and to try and address the gender gap. And countries tried, awareness creation, targeting outreach programs. And you see a country like Burundi had only less than 10, sites that were providing vaccines. So they started relying on outreaches to go and reach the population that was a little bit far. And the other thing that is important to note is that targeting both men and women with specific messages on the myth and misconception was a critical step in trying to make them, come for vaccine. And we see the trend between 2021 and 2022 changing after investment in trying to deal with these issues. Then the measures applied to reduce inequality. One, we had youth representation in outreach teams for some countries. Some countries were using youth-friendly timings. The others used technology. And the others, of course, used road shows, visiting venues, and of course, frequenting where youth usually stay. In terms of key consideration, one is that we are highlighting that gender consideration through the entire response, not only for this COVID response, but any other pandemic and emergency that we'll have, are critical and should be taken into consideration. Two, is that demand creation is very important. And I think we are well represented here by organizations that are good in this area. And I think that we are highlighting as the load of demand could be underestimated. Geographical coverage is critical, and a well-covered country will actually make sure that everyone will access COVID-19 tools compared to those that have already, centralized them far away, where a majority of the population, including the other privileged, will not actually access. These are critical. In conclusion, we highlight that we look at the beginning of the uptake of COVID tools. Men were the key receivers of these services, but women catched up after countries started responding to the social, needs of, service provision. So by addressing the bottlenecks that were there, or attempting to, we see that the women population also took charge, and they were able to take these COVID tools. The other thing is that when we introduce a new product, there are too many myths and misconception, misinformation, and it's our role to actually, deal with them and remove that. The other important thing is that gender mainstreaming is not only critical in the programming as we know it, but even with catalyzing the utilization of services from the household level. This is the supplier themselves. So when the supplier provided the service, we have seen that the populations within our region will not only take them, but they need to be assisted to understand the importance so that they accept, and then they are able to actually pick. In terms of the recommendation, I'll make some few here. One is that gender and other roles and other dimensions are critical for us to always consider within the pandemic. The other thing that is important is that we need to sustain risk communication through targeted messages for different populations. Third is that new products, and here we are talking about the COVID-19 vaccine messaging, should address doubts regarding efficiency, efficacy, and safety to the population in a way that people can actually align to it. Correction and reporting of data by other stratified characteristics are important. And I've noted this morning that Dr. Langat, you did not, in our registration, I was waiting to see your gender when we were registering. Right? Then it told me, thank you very much. So I am still wondering when I will register my gender. So I think these are practices that we must, the data is as good as how it is good when it is being corrected. And in a researcher, will tell you that. So I am not focusing on this one, but I think we need to lead from front, make this a practice to actually separate our data in a way that we are able to do this kind of analysis without a problem. The last one is that there's a team of researchers who have invested in understanding gender dynamics, how they should be mainstreamed, how do you engage community, and these people, we live with them. So it is important that when we are addressing to this kind of, pandemic in future or any other, emergency, please, it will be good for us to have them and hear their view. With that, thank you very much for listening to me.
Thank you so much, Dr. That's he has taken us through a very quick evaluation of how did we perform. And I think the question is, when you're applying for a job, there's that last line they put over there in the advertisement. It says we are an equal opportunity employer. And the question we have been asked is, is our health system an equal opportunity carer or provider? healthcare provider. And I'm glad that in as much as we were told we did not start off on a winning note, we changed our ways and we were able to change that narrative so that disproportionate access to healthcare was actually addressed. So I want us to shift gears. Let's give him a clap first of all once again. And I think really it's not even just so much to him, but actually to the many men and women that have been working in our health systems across East Africa in terms of making sure that healthcare delivery is accessible. I want us to shift gears now, and I want to invite back all of our presenters to join me here on the platform. I'll also request for some assistance to do away with the podium so that we can have a quick discussion and then open up for Q&A. We want the Q&A so that you also have a chance to interrogate them. So we'll also make sure it's an equal opportunity interrogation. So please have your questions ready. I have my Mwakenya here. I've been listing questions as they were talking. So I hope you've also been doing the same. As they do that, I also want to invite a few more people to join them, a couple of people. The first one is Mr. James Kamau. James Kamau is a renowned health advocate and activist, both here and also internationally. He's also the CEO of Kenya Treatment Access Movement and a member of the Global Fund Advocacy Network, or GFAN. Karibu sana Kamau. I also want to invite from the pharmacy. He's an expert, the deputy director of the inspectorate at the Pharmacy and Poisons Board. Karibu sana Daktari. You'll tell us a little bit about some of the work that you're doing and whether what we are hearing is correct. And then also, I want to invite Ms. Jerop Limo. Jerop Limo is the executive director at Ambassador for Youth and Adolescent Reproductive Health, also known as the youngest CEO within the CHReaD fraternity. So Jerop will tell us a little bit about the work she's doing within the community, and also, of course, representing the voice of the youth, which she's done very well for a long time. So I don't know whether we all have a microphone. Is it possible? Gender balance. Thank you. These are some of the things we need to correct. So I think I shall. As we were told, we learn and we correct. So next time we shall ensure that it is corrected. But that said, I think I will. If I sit with you, I will obscure some of you, so we can remove this chair. Maybe just. And that allows me to just stand and talk. Because of the gender balance, and I've been corrected already that what we have is mostly a man panel, and our indomitable youngest CEO. How are you doing? Do you have one microphone that we can share? I can, okay, let's, yes. So I think maybe to even things a little bit, I'll start with you. How are you doing?
It definitely feels weird to be seated here with all men, but I got this, I guess.
Awesome,
yes.
Awesome. Thank you. The good thing about you is you never disappoint. So what I want to request, please tell us a little bit about yourself. I know I've done a bit of introduction. Tell us who you are again. Why is it that you do what you do? And then I'll ask you one of the questions that I needed to get some enlightenment on.
My name is Jerop Limo. I work with adolescents and young people in their diversity. Of course, when you talk about gender, when you talk about how people autonomously choose to exist as, hence the word in diversity. I majorly work in the HIV space, and I do the work I do because I want people to be able to access healthcare at the end of the day. I want people to be able, the young people to be able to access correct information around health. And I want young people to learn and normalize their habits of better health-seeking behaviors, even as they grow to be adults. Yeah.
Thank you. And I think if I can clarify, you're saying we should not just look at gender, but you're telling Prof there that there's another checklist of the age bracket that should also be part of the equity. And maybe as a quick way of opening up the discussion for the panel, we've listened a lot to how COVID affected the delivery of healthcare for AIDS, TB, malaria. You talked about HIV, which is an area you are an expert in, but also reproductive health. How has this been? Did you see, what was the impact of COVID on healthcare delivery for reproductive health and generally to the youth and adolescents?
Just looking at the situation during the pandemic, before the pandemic and immediately after the pandemic, something that has been mentioned is access to commodities that was majorly affected. Of course, uptake of health services was affected because nobody wanted to go to the hospital. It's COVID time, nobody wants to interact with the spaces that are hosting and caring for COVID patients. But majorly we had a lot of shortage of commodities, TB commodities, reproductive health commodities, HIV commodities, majorly for even reasons of supply chain. That is one of the feedback that has been mentioned by the COVID report. And I think COVID also showed us how poor some of our health systems are. We had a lot of issues, lack of beds, lack of oxygen, lack of accessibility of these services because of finances and all these aspects that really contributed to showing how health services are not majorly accessible to some of the communities we actually serve.
Thank you so much. Maybe we can go back to Dr. Moi. And you're also a very effective champion for equity. And as you are talking about the landscape for health equality, healthcare provision and the equity aspect of it across East Africa, what stood out to you as the most vulnerable group? And also in terms of the access to healthcare, who are the ones that were, when we said no one left behind, as we do for universal healthcare, who should we really make sure we capture?
Thank you very much. I think according to my understanding of our terrain within the region, we find that of course they are at the number one comes the people who are physically challenged, who we didn't have specific programs targeting them, and of course limiting the ability to access the COVID-19 vaccine, diagnostic, treatment, and such. But crucially there, actually, with serious problems, is a poor woman. So, women were largely left behind. But if you are now poor also, that means you are poor in all the socioeconomic indicators. So if I would say like that, you have no money, you have no education. You are a very vulnerable person. And I think these were the key main people. And when you look at the countries that reported serious disproportionate in terms of equity in provision of service, like Southern Sudan, you'll find that the ladies who are in very poor setting were really left behind.
Thank you so much. And coming to Dr. Abuya, you gave us a really interesting perspective of how we have this do I call them verticals within the healthcare systems of the HIV, TB, malaria. And I think some of us used to call it the ATM, AIDS, TB, malaria. Well-funded, much more robust compared to the rest of the health system. And it's interesting, even within those very better resourced verticals, there was actually some impact of COVID. And my question maybe would be, what can we learn from the HIV, TB, malaria that really, maybe let me put it this way, how can we translate or how can we scale up the learnings of those three verticals to the rest of the health system? What's the main barrier and what do we really need to do?
Thank you, Dr. Raj. I think the greatest challenge we see across vertical programs is the idea of breaking those silos. My suggestion is that there is need to think about how do we sift the learnings from these vertical programs that have been well funded over time and use those learnings for across the health system to increase its resilience. And one way to think about that is to diversify those learnings. As we saw there, the effects of COVID-19 on these three disease programs were quite moderate. It appears like the providers, the system shielded the users compared to other diseases, meaning that for well-funded programs over time, creates strong systems. And then we need to borrow those strong systems and apply those lessons across other disease programs and break the silos by ensuring that we can integrate service delivery across those areas. So my take is that having a heavily funded programs over time would need now to diversify and dissipate those learnings for effective resilience of the healthcare system.
Thank you. And maybe Dr. Munyoroku, and thanks for the amazing work. I don't think it's often that we get to understand what happens within the government machinery called Pharmacy and Poisons Board. And today I think the presentation earlier by Chris was a great eye-opener of what does it really take for accessing healthcare. And there were so many, I kind of was listening to the recommendations and they were all really important and very transformative. Everything from how do we split the role of professionals to products, and how do we ratify AMA, how do we move to level 3. So how, maybe tell us a little bit in your own words, how do you keep going? How do you avoid being overwhelmed? And what is the best support you think you'd want to get from the members in this room? We have great policymakers here across the county, across the region. We also have civil society, and even some of the academia doing R&D. So what would you say would be the biggest support that you would need? The doctors told us, and nurses, they said, ask psychosocial support. Mmetusahau. Pharmacy and Poisons Board, what will you tell us?
Okay, thank you, Dr. Karanja. Let me just give a statement on Pharmacy and Poisons Board is the National Medicine Regulatory Agency in Kenya, created by Chapter 244 of the Laws of Kenya of 1957. In 1957 and today, medical products and health technologies are totally different. It's a totally different picture. So all along what has been happening, we've been trying to amend what we call piecemeal amendment of that law to bring it to speed with the regulatory world or the products in the market. Now, recently, as Dr. Chris alluded to, we were being assessed by WHO, and they have done it across Africa. As he said, in Africa, there are only Ghana, Nigeria, Egypt, and Tanzania who have attained maturity level 3 in their ranking. There's no maturity level 4 in Africa. Now, for PPB, if you see the report were evaluated from around 20th June this year to about 2nd of July, If you look at the exit report, the only thing that prevented PPB from attaining maturity level 3 were two things: law and human resource.
Wow.
Because they want everything you regulate to be expressly written in the law. We do these functions, we do them, but they said those things that you are doing, some, very few for now, have not been expressly mentioned in
our
CAP
law.
244. And you know how difficult it is to amend a law. So
Yes.
now that is the only bit, and human resource. Yes, those two are sorted. PPB tomorrow would be in maturity level 3, and they are being sorted. So WHO will give us a revisit January 2023 to see if we'll have sorted all those things.
Excellent.
And then we go to maturity level 3.
I think, can we give them a clap? You know, it's really interesting because what in essence we are being told is that the impediment for private sector development, which the maturity level 3 not being them, is in essence almost overcome. So what we really need is champions in parliament and to make sure that we get the right legislation in place. And then the second part is also, you talked about human resource, and maybe let me come back to that. So when you talk of human resource, what is the barrier? Is it that we're not getting enough financing to Pharmacy and Poisons Board? Is it that we don't have enough talent, and so the universities need to train more, we need to import experts? What is the issue?
Now, number one, let me first state that PPB has the most educated team of experts across the regulators in Africa. We have almost 3 PhDs. Everybody else has a master's from top universities in this world. But the numbers, all the technical staff at PPB are not employees of PPB. They are seconded from the MoH, Ministry of Health. PPB funds its activities from the fees they collect from registrations and all that. So those funds are not enough to employ the technical staff. So that's why we depend on the mother ministry. They have been deploying, like me, I'm an employee of MoH, but I have been deployed at PPB. So that is the issue with the staffing, because once the government policy on staffing, if it's frozen, that means you cannot get more on the other side.
Okay.
Yes, so the issue is if PPB can be funded or facilitated to employ its own technical staff, like all the other regulatory agencies in Africa, and that became an issue even during the audit by WHO. So that's why I'm telling you, those are just the few issues that we need to sort, and we are home and dry.
Thank you so much. And I think your points are very well articulated. And we do know what our work is, especially within CHReaD, in terms of then supporting you. I want to come to Kamau. And I think as you're seated there listening to Dr. Mnyoroku, being the renowned advocacy and activist that you are, how would you, what do you think are the main barriers? Why is it that government is really not providing the kind of financing and the laws that are necessary? And maybe also in terms of the mobilizing towards that effort, how would you, what advice would you give to the members here?
Thank you very much. One, I like what you have said, and it's important.
Just lift your microphone. Okay.
Can you hear me now?
Yes.
Okay, thank you. I like what he has asked, and one, I think CHReaD and being a CHReaD member, I think that work has been cut out for us. And I think we need to move with speed to make sure that the necessary legislations are put into place, and also to make sure that a budget line is put into place for it to continue. it is extremely important that we also ring fence whatever funding that they have and make it more independent for it to move like all the others, all the other organizations that are there around the world. And I'm sure if they are given the free hand, they would do it because, like he says, they are the best placed this side of the Sahara. I mean, within the Eastern African region.
Thank you.
Then,
and maybe one other thing I wanted to ask is, I know I forgot to mention that you're also an economist, and so you also have an interesting vantage point, and you brought it out immediately when you started talking about budget line, ring fencing, the words that when we are talking about health, we forget. Then when decisions are being made at the Treasury, sometimes we realize we are shortchanged. What, out of the conversations that we've had, the three presentations, and given the work that you also do within the movement that you're leading, what are the silver linings that you see in as far as COVID is concerned? We've had some learnings, yes. Of course, it was still traumatic, but what else would you see that is actually worthy of note that we should keep in mind?
Thank you very much, Dr. Karanja. One, and I said this, COVID was one of the best things that happened to Kenya. Why do I say that? The washing of hands helped us reduce by nearly 40% the cost of disease bacteria infections. And I think that issue of hand washing must continue for it to be a public health issue. The other one that happened is that equipment of X-rays, the oxygen and the other were distributed widely. I do not want to enter as to what was the effect of them being placed there. But like Terry has just said, the equipment is out there, but they don't have the human resource to be able to run this. And I think it's important to put the issue of the human resource there. And lastly, we have a disaster management fund that does not work. We have seen the issues of COVID and now Ebola. We need to have that fund running. We already have a budget line and we need it moving because we continue relying on donor community from a lot of donor funding. And suffice to say, the ministry has come up with a system or a policy on sustainability of funds for diseases like HIV, TB, malaria, and of course now the COVID that are not fully funded. But we need to have that disaster management fund in place and ring-fenced so that we can be able to move and articulate at the speed within which we did.
Thank you so much. And coming to Dr. Masila, you know, you've introduced a lot of interesting things to us, maturity level 3, and a whole science of regulation that we typically don't see. And I think maybe coming out of all of this, maybe you can just help us to really understand without the academic words, what does this maturity level 3 really mean for us as a country, for us as a continent? When you say it's only 3 countries to date, you said South Africa, Ghana, Egypt, and Tanzania, with the maturity level 3. Why is it such a big deal? What will it change for Wanjiku.
Some of the country we export some of our local manufactured products, but sometimes because of some of these maturity levels, we're not able to go to, for instance, export to India and the rest. So I think this helps us to really target bigger markets, bigger economies, and our products really become world-class at the end of the day. If you're able to produce a vaccine and we have a PPB maturity level 3, we could supply, for instance, Gavi and the rest. So I think one thing is really key is it opens us up. Secondly is just the staff, the human resource. As soon as we attain that, there's also capabilities of the staff. We're able to reach some of the international organizations, attract international manufacturers. So this is key, but of course, we don't want to lose some of our staff. Once we achieve that maturity level, we want them to remain here. So I think back to the point, we really need to think about either delinking the PPB from the ministry towards a more independent, autonomous. Right now they're semi-autonomous, so autonomous body, which will really help them manage and be financially sustainable. I think last thing is we've seen a lot of, during COVID, a lot of research and development. I know Dr. Karanja comes from the R&D world. Kenya, we have Cambridge and the rest, but we need to move to a level where we're able to invest in R&D. I think CHReaD does a lot of this. And in terms of, we've had a lot of mRNA vaccines and all this, but we are not producing this, and we work with a number of international manufacturers. So there's need to think about a lot of technology transfer. So this brings a lot of this thinking into our country. Once we attain this kind of level, we move towards more research and development, and we're able to manufacture some of these very complex molecules where we always, as they say, Africa produces only 1% of the vaccine manufactured globally. So we need to shift that, where we have countries like India, which manufactures almost 80% supply of the vaccine, towards Africa. So I think we need to bring that expertise, and once we attain this, we could be able to negotiate with India, China, and some of the global powerhouses when it comes to regulation and also manufacturing.
Thank you so much. And I think it's a really, one of the biggest lessons from COVID was the disruption of the global supply chains. So our dependency on India, and you're saying Africa, we import 99% of all the vaccines. Wow. So yeah, we are in a vulnerable position, clearly. So I want to, before we release our panelists, I want to open up the floor for Q&A. If there are any questions or feedback, comments, please feel free, and also maybe request even for the online participants, kindly just type your question in the chat and we'll be able to read it for you. Yes, I can see a gentleman here. So I'll do the roving mic, so don't worry.
Good morning. My name is Karaoke. I come from Meru. I have a concern on the issue to do with the trends of some of the pandemic diseases like cholera, which was very rampant before the COVID-19, among other diseases. For example, in Kenya, cholera was a big problem. But as you said, through washing of the hands, many of the diseases went down, just disappeared. And particularly, this government of Kenya, we have been able to save a lot of money in terms of buying drugs to treat those diarrhea cases. My concern is, how are we going to ensure that we sustain that the washing of the hands, the hygiene issue? Because you realize our attitudes and our behavior. Sometimes people forget that the washing of the hands is very key. And when I was looking at it, we needed to make some efforts so that we can see which ways, which direction are we going to take, so that we don't go back to where we used to, the things that we used to experience previously. And I'm giving an example of cholera because the whole country had a big problem for some years. I think from 2014 up to 2020. And the government has spent a lot of money to treat and to manage cholera, among other diarrheal diseases.
I think that question is going to come out, right? Maybe you can respond. Before you respond, maybe any other questions so that we can have some consultative report. Thank you. Hold on 1 second as the mic comes to you. Maybe any question on that side of the room? Going once, twice. This is good. Oh, thank you.
Thank you. My name is Margaret Lubale, Director of Health NGOs Network, HENET. And I wanted to just commend the gentleman that presented about the gender considerations. And for me, this is a recommendation to CHReaD, because I think his presentation raised a lot of possibilities in terms of follow-on research. Because when you look at the gendered nature of the COVID pandemic, I think he has just scratched the surface. But I want to commend, number one, that it was a man talking about gender, because people normally associate gender with women. And I think I must commend you on that. And I think some of the things that need to be looked at are, for instance, the cost of the burden on the woman. Looking at the health-seeking patterns and behaviors of men, by the time a man decides he is really sick and is now destined for the hospital, there's a lot of out-of-pocket expenditure to treat with the chemists and the local pharmacies before he admits he's about to die. And so what is that cost on the woman? What about the woman that has persons with disabilities? What about the single-headed household? In terms of the effect of the pandemic, if you look at the issue of the cost, the real cost of COVID, when you look at the other things that collapsed, the informal sector collapsed. 83% of women are in the informal sector. The industry, the hotel industry collapsed. Over 22% of women are in the hotel industry. So you are looking at all this collapsing and the burden still on the woman, and more men being infected than women. So what is the real cost in terms of COVID to the woman? And I think I want to say that there are more opportunities to really delve into this, so that we also inform the other response mechanisms and committees, and definitely ensure that the national committees have a good number of women, because 0% really speaks volumes in a pandemic that weighed heavily on women. And so I think for me, it's just to commend and to ask for further research if possible. Thank you.
Thank you so much. And those are really great questions and feedback. Dr. Boy, I hope you've taken note of that. And I think we have one last question from the gentleman on that side.
Thank you very much. My name is Nahashon Alwoka. I'm a regional advisor with the Pandemic Action Network. I'm based in Nairobi, Kenya. I have a question and a comment. And the question, and I would really like to hear from Dr. Msila or Dr. Timothy Abuya. When you made the presentation, I think it was very insightful. And there was the idea around introduction of new products, and regulatory issues was really key. But we know from this COVID pandemic, and of course even TB, malaria, there have been a lot of IP and TRIPS related issues that also have a bearing on the pace at which new products can be introduced. And I know this has been a point of friction between civil society, the private sector, and I think it's really good that we discuss some of these bold points, and it might fall outside the scope of this study, but I would really appreciate to hear your perspectives on, to what extent the IP related issues may have affected introduction of new products. To the comment, I think the three presentations and the findings from the three studies are really critical and helpful. I feel the discussions are really beyond just Kenya. It should not just be a national conversation, because health security is really a global issue. It's a regional issue. And so we must find a way of taking these conversations to the regional level and get them also to inform global discussions. We know there's the discussions that are happening around the pandemic fund. We have the international negotiating body driving, consultations around the pandemic treaty. How do we bring these findings to inform some of those conversations? And I'm really happy that a number of colleagues from Amref, CHReaD, and many others here, Kanko, are part of some of those regional and global conversations. So how do we consolidate what we're already doing and bring these researches, the findings, to some of the platforms that we have access to also inform and highlight, discussions at that level? Thank you.
Great questions, and I think really interesting perspective. How does IP feature in? We've also heard earlier about looking beyond health and understanding the context that this pandemic is occurring in, collapsing of industry, sectors of employment. So let me go over to our esteemed panelists, and maybe you can be kicked off by Dr. MoH.
Yeah, so quick ones. One is that I think there is serious learning that we need to do, more so on translating, research data into policy. Because when we move from, generation, as these reports have done, to actually informing and changing policy to address those issues, then the research agenda becomes such an important thing in driving our way of programming. And of course, an important thing then relates to the cost as highlighted. So I think further analysis really need to also be done on this cost issue. Still remains anecdotal, so to speak, as of now. We'd want to see, the reduction in communicable diseases. What did we gain from there? What did we put in to get that output? Because it's more of prevention, but we have very little information on financing of prevention interventions within our domain, because we are heavily curative firefighting country. That's what we are, so to speak. So more evidence, I think, could be generated on, to really guide the transmission of the research work to change the policy and the mechanism of that transmission, which ideally may not involve, all the people in this room. Policy decision-making, changes of law would require other multi-sectoral players, including our political class. How much do we do to make sure that they understand these research components that we are generating, the implication and impact of the same, so that they are able to be implemented in the contemporary world? Thanks.
So perhaps I would like to comment on two things, just to pick up from Mwai's comment around costs. Our gentleman from Meru suggested that, we may have saved a lot of money from reduction of other bacterial infections or other diseases from preventive strategies that were put in place. However, as Mwai is alluding to, what is the net effect of that? In other words, you may save X number of resources, but the same amount of resources are being used to and reprioritized to fight the pandemic, as is said. So in the end, a better study needs to be done to look at the net benefit of what we have gained from preventative strategies over time, vis-a-vis the costs that we've used to fight the pandemic. I'll address the second issue of IP versus, and my colleagues are better placed to do that. But one of our recommendations was to set up a buffer of supplies over a period of time for the region, so that as even the big pharmaceutical companies fight over IP issues and technology transfer, we still have some form of supply that can sustain us for X number of time. And that can only be well structured if we have a good, as Kamau was alluding to, a good mechanism for disaster management, a basket of funding that can allow us to draw from it and don't deplete and reprioritize resources that have been used to fight the NCDs that we do every day, the service delivery that we do every day. In other words, such a buffer will help us be able to overcome, as Africa's Kenya and East African region, the challenges that often are seen when new technologies, new products come into the market. Thanks.
Thank you. Thank you very much. Like has been alluded by the previous two speakers, prevention is extremely important. We need to invest in prevention. And I think, like Dr. Abuya states, we need to do a cost-benefit analysis of prevention so that when we go to the policy makers and others to ask them to put money on the table, they will be able to see clearly what the return on investment is. Prevention is also one of the drivers of UHC, or universal health coverage. And I think we need to do it an uptick. The question of how do we maintain the people to continue hand washing? I think the problem is adults. So we need to go to the schools and make sure that it is incorporated within their system for them to be able to learn, so that when they come out, they will continue with it. Otherwise, adults, once they are free, they assume everything is fine. So I think we need to incorporate this very widely. We also need to incorporate it in places like of our worship and whatever it is, and our cultural basis, so that we know and the issue of bacteria. And also we need to go back to show what those so-called simple bacteria infections are and what they can cause.
Thank you for the comments. I just wanted to address two, and I'm sure some of my panelists have addressed. Mr. Kamau says prevention is better than cure. And in addition to hand washing, we had the sanitizer repurposing. Everyone was making a sanitizer. So we hope that movement towards repurposing facilities that we had, even had hospitals, institutions making this. I think this needs to continue. And for instance, mask wearing, Dr. Langat will tell you TB, I'm sure reduced a bit because of a lot of mask wearing. I think this really is important for us to ensure these basic public health measures are still practiced and built into our programming in terms of moving that forward. On the point, I think there was about IP and innovation. Beyond the COVID, we have a lot of other innovations, even here locally. We spoke to innovators, people who develop, for instance, Tibavent, the ventilator. Up to today, they are still doing clinical trials. So there's still a lot of opportunity to ensure that we have proper sensitization of our innovators, and also how to teach them, especially from the regulator and also other partners, to introduce these new products. Normally, some of these products, if it's medicine, vaccines, takes almost 20 years, 30 years till you see the product out there after clinical trials. So there's a lot of money required to invest, but definitely there are other ways. Definitely an example is, for instance, the mRNA technology. It was there, But quickly in 2020, the scientists came about and repurposed. My final point is just the partnerships. We need to enhance partnerships between public sector, private sector, and academia. We saw that a lot happening within the COVID pandemic. Quickly, academic partners and private sector and public sector partners really helped develop some of these new products. So I think a challenge to the Ministry of Health and also the public-private partnership unit, it needs to really move towards ensuring some of these discussions are taken forward. Thank you.
I can invite Dr. Meroku, any last closing comment, and also Jerop on last comment, closing comments, and also the cost, the hidden cost to women. There's a big question on that we've kind of tried to attempt, but if you could help us.
Yes, from where we stand at Pharmacy and Poisons Board, would say lesson learned from the COVID era. It has accelerated the uptake of IT, use of IT, which has enhanced our working, which is very good. And on the pharmaceutical side, manufacturing. COVID actually has accelerated manufacturing, local manufacturing of medicines. In the last 3 years, there are like 5 new entrants, manufacturers in this country that we are guiding through at various stages. They want to establish manufacturing here in Kenya. So it has been a good thing, as it has been said. It has taught us 1 or 2 useful lessons. Thank you.
Thank you so much. Jerome?
So one aspect is that, of course, continuously and on a daily basis, I think many of our communities struggle to raise money or to access healthcare. And especially when looking at the cost of living right now, many people are not able to afford healthcare. And a woman pale kwa kibanda will tell you, should I put food on the table? Should I go and buy and go for that X-ray or go and access that TPT in that facility and whatnot? So I think over time, with the cost of living and the resources that our communities have, many of our people choose to do other things as opposed to accessing healthcare. And that is one of the aspects that was being mentioned, that we choose to go to a pharmacy and buy Panadol and headaches and drink ginger and lemon as the situation gets worse, as opposed to directly walking into a facility and actually being checked and understanding what is the actual problem. So one, even as we talk about having better system, accessing services and ensuring that local medications and commodities that are available here are actually utilized and the market is opened. Even as we talk about research and development and access to vaccines and medication, there is need to continuously empower the community. 1, to uptake services, and number 2, to realize the importance of health. I do understand that prevention is better than cure, and there is need to continuously ensure that we have a touch with the community, that we do not just speak here at the national level, but ensure that our communities understand that just because we are no longer in the serious time during COVID, we shouldn't stop washing our hands, or we shouldn't stop wearing masks, or we shouldn't stop sanitizing. If you're coughing, that you shouldn't just stay at home or drink hot water, but it's okay for you to actually walk into a health center and ensure as a country. We will tell people to go and access these services, but are the commodities really there? Stockouts and inconsistent and consistent stockouts of these commodities. So how do we ensure that we actually have these commodities, that the human resource is there, that the machineries are working and functional and they're able to be maintained over time, and that we are continuously pushing our government to be able to allocate resources. We're talking about domestic financing and proper utilization of these resources, especially as we think about health and think about how much money comes from donors and how much money comes from our own country, and why it is important for our own country to actually invest in health. Yeah.
So much. And I think with that, let us give our panelists a round of applause. I request you to take your seats again, and a quick switch over back to bring back the podium so that we can move on. I think this has been a very interesting conversation, and I think, as I said earlier, So I think we've had a fairly good conversation, and we're all enlightened now. As I said earlier at the very beginning, this is one of the big partners in making all of this work possible is the government of Kenya. And so to introduce our keynote speaker, I want to request Evelyn to come and take us through the next step.
Thank you so much. That was such an informative panelist, or panelists. Yes, but I think we need to appreciate them in a better way. And you know, we are in the football season. So we are going to appreciate them in a cheer. You know the one, do you have Arsenal fans in the room? Yes. Yeah. Arsenal fans, assume you're watching the match between Man U and Man City. Yes, eh? Yes. So let's celebrate. Let us appreciate now. We're in that scenario. Arsenal fans appreciate watching that team between Man U and Man City. Arsenal fans, where are you? We don't have any. Okay. Man City. Do you have Man City? Man City fans? We don't have. Okay. Liverpool. Okay, thank you very much. So Liverpool, let's appreciate the team that was just here, the panelists. Okay, let's just clap for them. Yeah, my team remains Gor Mahia. So at this juncture, we want to have the opportunity now to listen to the government, and I want to invite Dr. Meshach Dirango to invite the representative from the Office of the Director General. Dr. Meshach, karibu.
Thank you very much, Evarine. And in the interest of time, I have immense pressure right now to introduce to you Dr. Simon Kibias, a longtime friend, once a classmate, and currently Director, Health Standards and Quality Assurance at the Ministry of Health. Dr. Kibias will be speaking to us on behalf of the Ministry of Health and also on behalf of the Director General, Dr. MoH, who is not able to join us today because of Ebola preparedness and all that. So welcome, Daktari, and thank you for being available to be with us today. Thank you.
Thank you. Asante sana, Dr. Meshach Dirango. Thank you, Meshach, once more. Good morning, everyone. Good morning. Yes, you have been told my name. I'm the Acting Head Directorate of Health Standards, Quality Assurance at the Ministry of Health. And I'm here this morning to join you and represent our Director, Acting Director General for Health, Dr. Patrick Hamoth. I think we really have to thank God for this day today. I think I'm also very happy that I've joined you this morning to listen in to the ongoings in this workshop. And I have been able to listen enough. And I think before I say anything about what I heard. I think I would like to recognize all the partners present here and all the members of the coalition for the health research and development members, all the experts present here, and all other stakeholders who have been invited. I think before I read the message from the Director General for Health, I've been lucky in my journey in the health sector to work at various levels and various programs, including working with the primary healthcare department. I've also worked with the TB program, and I was happy to see my colleagues. We worked together before, Dr. Langat, Dr. Chris Masila, and others. And I've also worked as the head of Disaster Risk Management Division. And what I've heard today being presented here by the speakers that have spoken before all of us here, I hear a lot about emphasis on preventive promotive health, which I think is very key and should happen at the primary healthcare level. So there's a lot that was said around there. And I hear also the need for preparedness, a lot around having also prepositioning of commodities and supplies, and even now vaccines and many other equipment and so on. So for those who are familiar with the disaster risks management cycle, I think we probably are in the recovery phase of this COVID-19 pandemic. And I would like to summarize everything by saying that all what I have picked was we are very alive to the fact that we need to build back better after this COVID-19 pandemic. It was an opportunity for Kenya to respond the way we did, and I think we shall be vindicated once the post-action review report is done. All the good things and the good I have done, and then what they intend to do going forward shall come out. And I strongly believe, as part of the support systems within the Ministry of Health, we shall continue to work with our partners, all stakeholders, to ensure that we invest in the resilient building activities so that our system, our health system, remains resilient, because the best time to prevent the next pandemic is now. So I was very happy to hear all the deliberations that have been discussed, the question and answer and the panel discussions, and they were very rich, and I can't be happier than now as a health expert to know that Kenya is really endowed with the expertise and enjoys a lot of support from our partners. And there's nothing we cannot achieve if we act together. Until all of us are safe, we are never safe until all of us are safe. We've just come, I had also the privilege recently to represent the Director General for Health in Arusha, the East Africa Community Council of Ministers meeting. The first 3 days is usually headed by it's a discussion by the panel of experts, and I was representing the Director General of Health and chaired the meeting. All the good things that we mentioned here were raised there. The issues of having a medical agency, I heard that that time a member state wanted us to take note of the fact that the issue of AMA had been concluded. Then as we were struggling, Rachel knows, to say, hey, hold that one. We thought Kenya would still bid for it. So, so we managed to stay hold of that statement, but shortly later, a few weeks, we were told it had already gone. So, but since this was still within the East Africa community, as a EAC region, we're still lucky to have an agency like that to champion HPTS in our region, the logistics of HPTS. So I'm very happy in concluding my own remarks that we are doing this in the context of East African community. The issue, the study that CHReaD came up with and the report is context very specific. It's East African community and involved several countries from within the East African community. So Kenya alone cannot be safe when our neighboring countries are unsafe. Yes, for you to be able to prevent TB outbreak, we all must be TB free first. I mean, all countries must play part. So thank you very much for having me this morning to join you in this. And it's my pleasure now to read the message from our Director General for Health. Good morning, ladies and gentlemen. It is my singular honor to preside over this event for the launch of the 3 reports on health security in a post-pandemic and world, namely, 1, the systemic equity and gender issues affecting products and introduction and access to COVID-19 tools in East African communities. 2, evaluation of the regulatory processes of health products in Kenya. 3, experiences and effects of COVID-19 on accessibility and delivery of HIV, TB, and malaria services among healthcare workers and users in Kenya. From the onset, allow me to share my sincere gratitude on behalf of the Ministry of Health to Global Fund for their support through Amref Africa and the Coalition of Research and Development, CHReaD, together with its partners for undertaking the 3 studies in Kenya and the other East African countries. Ladies and gentlemen, the truth is the COVID-19 pandemic has led to a dramatic loss of human life globally and continues to present unprecedented challenges to public health, food systems, and the achievement of sustainable development goals in general. It has been a powerful demonstration that when health is at risk, everything is at risk, and that there is no global security without local health security. Therefore, immediate and purposeful action to enhance preparedness and progress towards universal health coverage based on foundation of primary healthcare is more urgent than ever. Ladies and gentlemen, in practice, this means that we must increase investment towards resilient health systems founded on robust primary healthcare as a first line of defense against outbreaks with epidemics and pandemics potential. Indeed, the government of Kenya has demonstrated commitment to strengthen its regulatory environment and support the efficient evaluation of medical products and health technologies. In addition, the government has also developed a robust regulatory framework, which includes a number of regulatory agencies, each overseen by various government ministries. To this end, these strategic reports are a foundation towards strengthening health security during and the post-pandemic period. Ladies and gentlemen, Africa is facing a major disparity in its COVID vaccine access relative to any other region in the world. The Ministry of Health's vision is to enable integrated approaches to improving health system resilience for universal health coverage and health security based on a foundation of primary healthcare with efficient community engagement and greater focus on equity. We can only achieve this through investment, best practices, which will enable the region to accelerate actions through well-coordinated and harmonized efforts to improve health security. It is against this backdrop that the ministry lauds the urgent actions leading to the launch of these strategic knowledge materials that are pivotal to not only to surviving this global pandemic, but thriving in its aftermath and beyond. Ladies and gentlemen, firstly, since the onset of the outbreak, countries have had to make difficult decisions to balance increasing demand for COVID pandemic response with the need to maintain equitable delivery of critical services. The analysis of systematic equity and gender issues affecting products introduction and access to COVID-19 tools in East African countries is an evidence base that can help to address gender-related barriers and inequities in communities and health systems. Together, we must champion gender equity and a rights-based approach in all our work to ensure that no one is left behind. Secondly, preventable deaths have increased globally, not just from COVID-19, but due to the widespread disruption to health systems services that the pandemic has caused. While health products and technologies are interconnected with commodity supply chain, they are also critical elements of a well-functioning health system and vital input to advancing national and regional health security goals. Certainly, the report on the evaluation of the regulatory processes of health products will help us to identify opportunities and challenges that hinder or enable efficient review and turnaround time of health products and innovation in Kenya. Ladies and gentlemen, lastly, at the onset of the COVID-19, countries implemented preventive measures to manage the spread of the disease with limited attention to healthcare workers who are central in diagnosis, treatment, and containment of the pandemic. It is true that we will be living with COVID for the foreseeable future, and that we will need to learn to manage it through a sustained and integrated systems which will provide a platform for preparedness for future pandemics. It is my hope that we can learn from the report on lived experiences documented by healthcare workers that support HIV, TB, and malaria services and their clients. Ladies and gentlemen, in closing, it is my hope that after today, we will be confident of our partnerships and leverage on these reports to continue protecting public health and achieving health security in the region. We will only succeed if we are in control and take up initiatives that are adapted to our local settings. Thank you so much.
Thank you so much, Dr. Kibias. We want to assure you that all the efforts that we put are to complement what the government or the Ministry of Health is doing. And the end goal is to ensure that the Kenyans achieve good health. So we're going to appreciate Dr. Kibias, but after we finish the next session, which is launching the reports, that is what you have been waiting for. So I'm going to request the following to join us near that, I call it a podium. Yes, so that we can have the lounge. Starting from the KCM representative, Josephine. Yeah, join us. All the panelists, kindly, let's go to this side. Dr. Meshak, Dr. Nyalita, Dr. Chris Opati, representing the counties, Dr. Rakiro, representing Global Fund, and Dr. Langat, and all the panelists. So, Dr. Kibias, I wish to invite you again to preside over this event. Okay. So what is going to happen is that Dr. Kibias is going to cut the ribbon.
Oh.
Hello.
Yes. That's what you say. So imefika ile wakati ya kufanya ile kitu. They say language changes. Language is dynamic.
Okay. So just before we cut, let's assure that everybody is holding a book. Sorry. Yeah, everybody is having a copy of the book. Yes. So do we all have a book? Yeah. Let's lift up our books. Thank you so much.
Thank
you. Members of the state, are we okay with the streaming?
Thank you.
Are we okay? We can cut? Okay,
thank you. Thank you, madam. For the sake of our clients, the community, for Wanjiku. We're doing it for these documents that will take us to the next level. Yeah, this country or Kenya will now be towards the next level, and we Thank you. Thank you, everyone. I think that was awesome. Yeah.
I think we can just stand around here so that we can have a good view of the reports.
Okay. We can keep this.
Yeah, we make a cover. Are we inside the frame? I want to make sure naonekana. Okay, so that one is done. Oh, okay, fine. Okay. So thank you so much. So the CHReaD members, you prepare to join us for the photo. Okay. So as the CHReaD people get ready for the photo, We have some small gifts for the panelists. Dr. Langat.
Yes, let me have your attention, sir. And a moment for the Amref. And mainly, if we had the resources, we would have gifted all of you. But we just want to have a representation. And our appreciation really goes to the team that has supported us. So Dr. Kibias, before you leave, I want to ask Dr. Meshach to give you a gift. And then Rachel, Jerop Limo, Josephine Maura from KCM, and yes, Josephine. Yes, next is James Kamau. Yes. Rachel Kitiomi. Yes, Dr. Meshach, you should not tire because for the sake of efficiency, can we also have Dr. Kamau Karaoke from BPP? And Jerop. Then for the guys who presented, that is Jerop Limo. And then for our Master of Ceremonies, I think you have done a very good job. Yeah. So there's a gift for Dr. Karanja. Oh, she has a gift. Thank you, Karanja. Evelyn Kibuchi. Yeah, so yeah, there will be CHReaD members. You can take your photo here, whoever wants to. You are welcome. But I know the press had requested for a session for question and answers. So we are arranging for that. We'll try to get you representation of the panelists so that maybe you can ask any question for clarification. So we'll set it up, give us a few minutes, and then we'll get back to you. But otherwise, the floor is open. Please leave here with a photo that shows that you are here and you are contributing to expanding the public health space. Thank you.
Okay. As CHReaD members, I think we can take the photos later. Yeah? Or you want to take now? Okay, now that you're already here, okay, let's take the photos quickly. Okay, let's walk in fast. And we call it, it's a razzmatazz. Thank you. Thank you. Nikurige. No, naombesha. Okay. We can have our seats. Hello. I think we are going to organize after we have finished, so that we can release the other people back in the media. So we have vote of thanks. Yeah, then we have the. Who is doing the vote of thanks? Sylvia. Yeah. Nura Hoya. Nura Hoya. Yeah. Okay. Hello, hello, hello. Let's take our seats. We have one more agenda. Let's take our seats. Hello. Let's have a seat. Let's take a seat so that we can have a vote of thanks and final prayers. Okay. Before we give the vote of thanks, we still haven't Dr. Kibias. Dr. Kibias, we still owe you an appreciation. Yes. Okay. Dr. Kibias, I have a message for you. First of all, thank you so much. The message you want you to take to the Director General is that we still need more money for research. The government has committed to invest 2% of the health budget to health research, but we are still at 0.8. We want to make you our ambassador. Go and talk to the Ministry of Health and tell them for us to make progress and advance research and development, we need an increase in that budget. Currently, we are 0.8, and we have committed to 2%. The rest of the African governments committed to 1%, but Kenya said they could make an extra 1%. So we are looking forward to meeting that maybe in the next 1 year. And thank you so much. Okay, let's appreciate Dr. Kibias, because first of all, he has agreed to deliver our message for having increased investment in research and development from domestic resources. Okay, we are going to give him that kilo clap because he's from the government. Okay, so at the count of 3, we are going to clap for Daktari. So 1, 2, 3, go. Moja, mbili, tatu, funga. Hii tutafungua. Fungua. Thank you so much. So we are now approaching the end of our program. I want to invite Sylvia Ayon from Kanko to give a vote of thanks. Otherwise, thank you so much. I have been your MC. I was co-MCing with my colleague, Dr. Karanja. My name is Evelyn Kibuchi. I am a TB advocate. I head an organization known as Stop TB Partnership Kenya. Our business is TB, and TB is our business. I also represent civil society at the WHO in a task force called the Civil Society Task Force. And I am also the African advisor for the African Parliamentary TB Caucus. These are movements of parliamentarians whose business is to do advocacy for TB in their individual parliaments. Thank you so much. I enjoyed being your MC.
Thank you, our MCs, for doing an amazing job since morning. It usually takes me more than 3 weeks to prepare a good impromptu speech. You can see on the program, it's my executive director, Alan Raggi, who was to give the vote of thanks. And he called me this morning. And you know, it takes me 3 weeks to do this. So I'll do it. This is my speech after 3 weeks. So, honorable key guest, Dr. Simon Kibias, our respected Dr. Bernard Langat, and our country director of Amref, Dr. Meshak Ndirangu, We are truly appreciative of your role and the entire CHReaD family, our most valued and invited guests, ladies and gentlemen. Good afternoon. Good afternoon. Or it's good morning. It's still morning. Okay, good morning. It is my pleasure to have been asked by my director, Alan Raggi, the executive of CANCO, to propose a vote of thanks. I want to ask you, what if this event did not have the two MCs? How do you think it would have turned out? Good? No, I think it would not have turned out well. So on behalf of the CHReaD family, we are immensely thankful to the Masters of Ceremony. Please stand as we applaud you, Dr. Karanja and Evelyn Kibuchi. Thank you. So the other guests who I'm going to also mention, as you are mentioned, you just stand for the others to applaud you. Yes, so our special thanks goes to one, the entire Amref family. Amref family, asanteni sana. Second, to the CHReaD members, all CHReaD members. Thank you so much. 3 counties, all the counties. I had Meru, Nyeri, Kiambu. Counties mko wapi mashinani? Thank you so much for gracing the occasion. 4, the Ministry of Health. The Ministry of Health. Yeah, and Pharmacies and Poison Board. Asanteni sana. The Kenya Healthcare Federation. Thank you. Our developmental partners, the Global Fund. Thank you. The Kenya Country Coordinating Mechanism. And most importantly, because I'm part of that community, all the civil society organizations, tafadhali, CSOs, where are you? Na siku hizi tumenyamaza. Hey, I was expecting to hear, where? Okay, communities, all the communities. Okay, thank you so much. The private sector, including the Jua Kali and our experts, the consultants. Tafadhali simameni, Dr. Abuya, Dr. Musila, and Dr. Dan. Without you, we wouldn't have the meat for this function. We are really appreciative of you. Thank you. Yeah, you may sit. And the members of the 4th Estate, media crew, asanteni sana. Asante sana. So finally, I would like again to thank you all for the gift of your time and to thank Dr. Meshak Dirangu for helping me understand that time, the time we spend here is actually the hours of our life. This event is memorable. This event has been great. If there is someone I didn't mention when I was mentioning all the others, not that you are less important, we value all of you for coming here. Asanteni sana, our ushers, and every other person who made this a success. God bless you and grant you great journey mercies home. Asante sana.
Thank you so much, Sylvia. That was actually 3 weeks speech. You did very well. We are now, this is the final session. We started with the word of prayer and we want to end with the word of prayer. It's going to be given by Mary Ngede, who is also a member of CHReaD. For the media, we are going to organize for you a panel so that you can have all your questions and also have some in-depth interview with the panelists. So that is being organized. So don't leave even after the prayers. Thank you. Mary Ngede.
Thank you, Evelyn. Hi, everyone. Hi again. I'll ask that we all be upstanding. And especially we want to thank God that our first lady and the second lady are almost pastors and others are pastors. So not because of that we are praying because God is good. So if you are not standing, there is something amiss. If you're not standing, there is something amiss. Let's pray. Father, in the name of our Lord Jesus Christ, we come before your throne of mercy yet again. We thank you because we prayed that you start with us, you continue with us, and you end this event with us. And indeed, we have seen you in every step. We take the opportunity to thank you, to worship you, to give you all glory, and to give you all honor. I want to thank you especially for what we had come to do here, just to add value to the lives of communities outside there, including ourselves. It is our desire, Lord. We have had so much that needs to be done, so many things that need to be influenced from political level all the way to the community level. And we thank you for the various organizations that were represented here in making this a good time to value to our communities. And therefore we ask you that as we go out to go and take action from what we have had here, you go with us and you send angels to where we are going, so that even if politicians, policymakers, they will listen to us and they will take heed to what we shall tell them. As we go, Lord, release us in your mercy. For we pray all this through Christ our Lord, who lives and reigns together with the Holy Spirit, one God, forever and ever. A clap to God and a clap to ourselves.
So we are all free to leave at our own leisure. I want to request members of the media, we can have a press briefing on this side where we have the banners and all that. So please feel free, and I also want to request for our speakers, the consultants, the experts, to also stay behind so that we are available to